Three, two, one. We are live now.
Namaskar and good evening, everyone. I welcome you all for today's webinar on lung cancer update. With immense pleasure, I would like to invite Dr. Vijay Agarwal, who is Senior Consultant Medical Oncologist, CMI Hospital, Bangalore, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you, Mrs. Ekta. In fact, we are looking forward to a very exciting next 2 days to talk about lung cancer updates. We know that lung cancer is one of the most commonest cancers in India, and obviously in our clinical practice, we see a fair share of it. But having said that, I think a lot of advancement has happened in lung cancer, and the things are changing at such a rapid rate that we're finding it difficult to keep up. So essentially, lung cancer today is what breast cancer was about 7-8 years ago, with constantly changing treatment protocols. And I think as long as we keep ourselves updated and are aware of the latest changes that happen, I think we would do right by our patient. So we have, like I said, an exciting evening set forward to talk about essentially the targeted therapy in lung cancer. And we will talk about the immunotherapy in lung cancer tomorrow, but today is dedicated to various targeted therapies in lung cancer, because we know that a vast majority of lung cancer are driver driven, and targeted therapy has in fact changed the landscape of how we perceive lung cancer and has benefited our patients all across. So to begin with, I think our first speaker, we have Dr. Rahul Sood. He's the head of department and a senior medical consultant at Command Hospital, Air Force, Bangalore. And he's going to talk to us about alectinib role in first line. Over to you, Rahul.
Thank you very much. I'll just take a second to load my slides, and I would thank the organizing committee for the lung cancer update, Dr. Vijay, Dr. Aditya, Dr. Kumar Swamy, and Dr. Vikram for inviting me and giving me this opportunity to speak on this important topic, that is the ALK and the role of LSNSA. In fact, when we talk about the ALK, I think it is one of the success stories in lung cancer. It is one place where we've been able to defeat cancer very, very successfully. And it is a potent weapon against the lung cancer. So ALK inhibitors and how the ALK inhibitors started and the journey of ALK inhibitors is what is my topic for today. So I have 15 minutes, and please do let me know when I need to finish. I'll try to finish within those 15 minutes. Right. So what is ALK? ALK is anaplasia lymphoma kinase. It's an important driver in cases of lung cancer. And there are various methods of detecting it: the fluorescent in situ hybridization, or the IHC, the RT-PCR, and the NGA. So we can detect it by all these methods. So as we see that the ALK is homogeneously present in the population, though it may vary, the mutation may vary by ethnicity, because we know that the ALK may be positive apart from lung cancer, even in lymphomas, in childhood, like neuroblastomas. And as we do more and more tumors, we find that ALK may be present in ovarian cancers as well. But the incidence of ALK positive non-small lung cancer is relatively uniform, whether you're from Europe, US, or East Asia. Now, this is the study which was done in India, and we get a lot of variation. There has been as low as 2.7%. There has been as high as 13.2%. But what we can say safely is at least 3 to 5% of our non-small cell lung cancer will have an ALK mutation. The incidence may vary with regions of India, but it is higher with individuals who are light smokers, and especially in individuals with never smokers. So heartening to see, though the figures are less, but 75,000 patients per year is diagnosed globally with an ALK positive non-small cell lung cancer, especially never or former smokers, younger patients, once again females, and it is mutually exclusive when you compare it with EGFR and KRAS. The clinical characteristics do not always predict, though there are some telltale signs that we have detected from probably case studies, case series and all. But otherwise, the clinical picture may not tell us that the individual may be ALK positive. So what started this was the Profile 1014 trial, and this was the landmark trial which told us that yes, we can treat ALK positive non-small cell lung cancer. And the drug that was introduced first was crizotinib, and we know that it was a molecule from Pfizer. This was the study which was a phase 3 open label randomized trial, which included locally advanced or metastatic non-small cell lung cancer who had not been exposed to any form of chemotherapy up front and had a good ECOG performance status. They were randomized into the crizotinib 250 milligram twice a day dosage versus the standard of care that existed at that time, that is cisplatin along with pemetrexed or carboplatin. The primary endpoint was the progression-free survival, and there were multiple secondary endpoints which included the overall survival as well. One thing that was important was that ethnicity, that is Asian versus non-Asian, as well as the CNS metastasis, was also used as a stratification for the study. And what we saw was alarming. That is a progression-free survival, which was unheard of, unseen, which started at around 9 months and continued as we went forward. A hazard ratio of 0.45, log rank, the p-value of significant log value, and the curves keep separating as we go forward. Also, the overall survival, since it was an intention to treat population, was also significant. And what is important is the 4-year overall survival rate, which was never heard of in lung cancer, was achieved with crizotinib of 56.6%. So the first study on this, yes, there were side effects, and we found out that the ALK inhibitors did cause problems in vision, diarrhea, edema. There were elevated transaminases, which many times did cause a stoppage of the therapy. But majority of the side effects were easily manageable as we learned to use this molecule. Also, we found that crizotinib, over a time period, the patient would progress. What was the cause of progression? The cause of progression was studied as various mutations that came. Though still 28% of ALK resistance is because of unknown mechanism, there are secondary mutations which are seen, and there are a number of secondary mutations which are seen. Copy number gains were another cause seen in 9% of the individuals, and other oncogenic drivers, predominant out of which was EGFR, MET mutations, RET mutations, which developed over a time period, were also seen. KRAS continued to be a problem in ALK positive lung cancer. So what happens to these patients who progress? So in came the second generation TKI, and ceritinib was the second generation TKI. This was again studied by the ASCENT-4 trial. This was a phase 3 trial. And once again, this was pitted against the chemotherapy, that is the pemetrexed with platinum-based combination. The primary endpoint was kept simple this time. It was only progression-free survival. And once again, alarming difference which was seen as compared to the previous trial with crizotinib. The graphs start to separate at origin itself, and they continue to maintain even at 24 to 27 months. But remember, once again, the comparator arm in this study was chemotherapy, which by now we know is not the standard of care in ALK positive lung cancer. It was much, much inferior to the ALK. So once again, a significant p-value and a good hazard ratio. However, individuals with brain mets at baseline and individuals with brain mets without brain mets, there was a statistical difference. Individuals with brain mets did not do that well, and they invariably progressed in the brain after a period of 18 to 20 months. Also, the adverse effects were similar to crizotinib. However, it was heartening to know that the grade 3 side effects were less. Also, the toxicity of both ceritinib and chemotherapy was more or less comparable, though there were higher GI toxicity and liver enzyme elevation in the ceritinib arm. Also, the GI toxicity, like I mentioned, diarrhea, nausea, and vomiting, surprisingly was higher in the ceritinib arm versus the chemotherapy, whereas these side effects of chemotherapy continued, as we know. But why did these two molecules not work in brain metastasis? And it is very intriguing to know. And the reason for this is that the blood-brain barrier is made up of proteins which are the PGPs and the BCRP. And what they do is they scavenge these molecules. Once they scavenge these molecules, they try to engulf it, and somehow they don't like these molecules, so they expel them out. That is, they efflux these protein molecules outside. That is, so therefore, the crizotinib and the ceritinib do not penetrate the blood-brain barrier, and they are pulled out of it. So that the CNS exposure of crizotinib and ceritinib may therefore be inadequate to control disease in this location. And therefore, in both these studies, we found the maximum site of progression was the brain. So 46% in the crizotinib arm, 42% in the ceritinib arm. This was the problem that we were facing. And therefore, we needed a solution for the brain in such individuals. So in jumped another molecule called alectinib. And this time the study was different because the comparator arm was not chemotherapy, because we know the chemotherapy no longer is the drug of choice in ALK-positive lung. So the alectinib was compared against crizotinib. And how is it different? What is important is alectinib is specific for ALK, much more specific than crizotinib. We know the crizotinib works in ROS1, MET, and other mutations. But what we require is a complete ALK blocker, which is alectinib. As you can see, it had a greater potency for ALK vis-a-vis the crizotinib, and also it is an in vitro kinase. That's why it's a second generation kinase and has a potent legacy as compared to the crizotinib. Also, the penetration to the CNS was better with alectinib. Unlike the crizotinib or the ceritinib, the PGP did not show that kind of love for this molecule and let it pass through the blood-brain barrier, thereby letting it act on the CNS disease as well. So the key difference that was seen with alectinib, and this is important, is the CNS penetration. The resistant mutation were less. It had a higher potency because it was against ALK, and it had a better selectivity. So the clinical application in the first line treatment was studied in these 4 studies, starting with the phase 2 AF001 study, the Japanese ALEX study, the ALEX study. These are all phase 3 study. And my favorite, and I think which is very pertinent to us, is the ELISA study, which was done mainly in the Asian population. So let's see one by one about these studies. The ALEX was the phase 3 study which started it all. And this was again in the first line, and alectinib 600 milligram twice a day was compared with crizotinib 250 milligram twice a day until progression. The primary endpoint was the progression-free survival. The individuals were stratified on those 3 important factors, that is the CNS metastasis, Asian versus non-Asians, and according to the ECOG performance status. The secondary endpoints was OS, ORR, and the CNS ORR. The data cutoff was analyzed from the start of 2017, first at 10 months, then again after 11 months, and then again after 12 months. So as you can see, the median follow-up, which started almost the same, 18.6 versus 17.6 at the primary analysis, start to widen to 27.8, 22.8 at 10 months. You add another 11 months and you get 37.8 and 23, and another 12 months, 48.2 and 23.3. So that is after almost 3 years of starting, the alectinib still works and is still ahead of crizotinib. So this was something which showed the superiority of alectinib. If we see the subsets, they were equally matched, but look at the CNS metastasis. The crizotinib, 38 out of 62, literally half, whereas in the alectinib arm, it was only 42 out of 58. Also, the time to development of CNS metastasis was lesser in case of crizotinib versus alectinib. This is the ALEX final mature investigatory assessed PFS. And as we can see, significant improvement, 34.8 months difference at 36 months, statistically significant, nearly 3 years progression-free survival. So that's why I mentioned ALK is a success story for us in lung cancer. If we see the exploratory analysis in the final PFS, marked difference which was seen. If we see crizotinib, hardly anybody reached the 4 years. And as you can see, you keep losing patients every year, and you keep losing patients more rapidly with crizotinib than alectinib. Even at 4 years, 43.7% of individuals were free who had received alectinib, something which is very, very scary. And these were the patient characteristics. And as you can see, this forest plot, everything favors the alectinib arm, and very heartening to see. This was consistent with the primary analysis, and the hazard ratio was statistically significant. So it gave you a progression-free survival of 25.4 months versus 7.5 months. And the ALEX phase 3 trial without pre-existing CNS metastasis was almost 40 months. That is, you're giving somebody more than 3 years of median PFS, unheard of till date. And look at the difference between the graphs. I think the lesser said, the better it is. 84% reduction in the cumulative incidence of CNS progression. So if it not only had a better benefit in individuals who had CNS mets, but also probably causes prophylaxis against CNS mets. So very, very, very significant. So this is the updated 5-year overall survival.
My apologies, sir. You are left with just 3 minutes to conclude the
I'll
presentation.
wrap up before that.
Thank you. Thank you.
So it had a better 5-year overall survival rate. So these are the 5-year overall survival rate. Superiority for alectinib versus crizotinib. Yes, side effects were there. Since the alectinib was more potent, so it had more side effects. But what is need to remember is the treatment with alectinib went longer. So therefore, it is not a direct comparator with crizotinib. So whatever you give for a longer period of time will have definitely have a longer side effect. However, nothing that was too alarming. These were some of the side effects: nausea, diarrhea, vomiting, constipation. So these were the things. And this is how we treat ALK inhibitors. We started with crizotinib, went on to ceritinib, and then lorlatinib. There were other ways of treating. We don't have brigatinib so far, but I think the best way of treating these individuals are by giving alectinib. You get something around 34.8 months of progression-free survival. And if the patient progresses, you can put her on the 3rd generation TKI, that is lorlatinib. I believe that is the next topic. So this is, I think, the correct way of going about. And remember, we are treating individuals with brain mets, without brain mets, delaying brain mets, increasing the PFS. So this is the NCCN and the ESMO. And for once, the American and the European agree to the same. That is, alectinib is the preferred first-line ALK TKI in both these studies. So all these data has told us that this is better. So why alectinib? Demonstrated a longer PFS. CNS metastasis is the only ALK TKI which has demonstrated clinically meaningful benefit in OS. And this is against crizotinib, not against chemotherapy. And it is relatively well tolerated and well characterized manageable safety profile, which is seen. So this is the ALEX data, and I'll not go further because I've already told you about them one by one. So it'll be harping on the same: CNS, PFS, OS. And this is what Tony Mock presented, the Asian versus the non-Asian subgroup analysis. What he basically meant was the alectinib works even better in the Asian population versus the non-Asian population. So somewhere we draw the benefit out of alectinib. So last 2 slides. So what we firmly believe, and in oncology, doing now what patients need next. That is what we have done in EGFR positive lung cancer as well. And I think we should do it in ALK positive lung cancer. And My last slide is, yes, we can break barriers again in oncology, especially in ALK-positive lung cancer, if we give a potent molecule upfront. Beyond barriers, beyond expectations is what is the harmony of Alecensa or alectinib. Thank you for your patient listening, and over to the organizers.
Thank you, sir. Thank you for the wonderful presentation. And let's move to the next session, which is sponsored by our academic partner, Pfizer. And for this, I would like to invite Dr. Vijay Agarwal, sir, who is going to talk on lorlatinib in first-line management of ALK-positive NSCLC. Over to you, sir.
Thank you, Ekta. I'm just going to share my screen. Can you see my slides?
Yes, sir.
Thank you. Thank you, Rahul, for that excellent talk and a good introduction on ALK mutation in lung cancer. And like you said, we have indeed come a long way from where things were about a decade ago, where ALK was just a molecular alteration, but now this field is becoming more and more crowded. So only a small percentage of lung cancer patients have ALK translocation, but the number of drugs are growing, and you've given an excellent talk on the role of alectinib, and I'm going to talk on lorlatinib, and subsequently Dr. Vamshi is going to talk on ceritinib, all looking at first-line treatment. So first-line treatment in ALK translocation has become a very, very crowded field. And I think at some level, we will need to sit and decide as to which sequencing to be used. But this, Dr. Rahul already shown that about 7% of the patients tend to have ALK translocation, which is a fair number of patients given that lung cancer is one of the most commonest cancers we see in our clinic. So ALK development has pretty much started less than 10 years ago. I think in 2017 was the discovery of the translocation, and the first drug was the crizotinib that was approved in 2012, which is just about shy of 10 years ago. And since then, there have been very many drugs that have come along. So crizotinib was the first generation drug. Subsequently, second generation ALK inhibitors came into being, which is ceritinib and alectinib. Alectinib we've just heard about, and ceritinib we're going to hear about next. And now we are already talking about third generation drugs, which is lorlatinib, which is the topic for discussion right now. And most recently, 2021, US FDA approved lorlatinib for use in frontline ALK translocated lung cancer. So there are obviously molecular differences between first, second, and third generation. The first generation being crizotinib, second generation ceritinib, alectinib. Brigatinib is a second generation, which is not accessible to us, is not available in India. And the third generation is lorlatinib. But more importantly, as we move further from the generation, we see the potency gets better, the activity against the mutation itself gets better, and you have better CNS penetration and activity going forward. Obviously, this was the first trial looking at the role of crizotinib in 2 patients who had ALK translocation, and you could see the median progression-free survival was about 9 months. Now, you don't see that with chemotherapy. With the average median progression-free survival with chemotherapy is about 4 to 6 months, and this almost doubled it. And this kind of heralded the growth of ALK inhibitors in lung cancer. We've already recently just seen these curves where crizotinib was compared with chemotherapy, both in second line as well as first line, and we see impressive progression-free survival benefit. And then subsequently, obviously, the role of ceritinib, the role of brigatinib, the role of alectinib. So various studies have been done, subsequently increasing the progression-free survival at every point. The highest so far being with alectinib, which was 35 months, or just shy of 35 months. Brigatinib with crizotinib was 24 months, and ceritinib versus chemotherapy was 16 months and 10 months with crizotinib. So you have 10 months, 16 months, 34 months. So subsequently, with every trial, with every new generation, the progression-free survival keeps getting better and better. Lorlatinib was a rationally designed drug to address the unmet need, particularly with regards to dealing with acquired resistance to ALK TKIs, as well as a good penetration and entry into the blood-brain barrier. Before we look at the main data, I think we want to show that we have our own Indian data from TMC. Looking at the role of lorlatinib in TMC, they give lorlatinib to 41 patients with a median follow-up of 16 months and showed a disease control rate of 73%. A median progression-free survival was 16 months and overall survival was 23 months. And only 3 patients needed dose reduction. So reasonably well tolerated with good clinical benefit. This is our own in-house study by Kumar Prabhash and team. So the thing about ALK translocation is that with every subsequent progression, so you have an ALK translocation, you give them a drug, and then they progress, and then you give another drug. So every subsequent progression, you get more and more ALK resistance that come into being. So the more powerful drug should ideally be used earlier on. So in this, if you look at a specimen, you have crizotinib, and then they develop resistance to crizotinib, and then move to brigatinib, and they develop resistance to brigatinib, and then move to lorlatinib. By the time they've gone to lorlatinib, they have had multiple resistance all molecular alteration. We know this data that the PFS of lorlatinib changes depending upon the lines of treatment that have been given before. So the earlier you use the lorlatinib, the longer is the PFS. So if you look at PFS post third line TKI is 6.5 months, second line is 11.2 months, and 2 prior TKIs is not reached based on these data that has been shown. So what we want to do is looking at use of pan-inhibitory agents upfront to reduce the development of resistance, and obviously the better drugs should be used upfront. The more stronger drugs which have wider ALK inhibition should probably be used upfront, which is what lorlatinib was designed for. So the most important trial for lorlatinib was the phase 3 multi-center randomized trial called the CROWN study. This study included all patients with stage 3B and 4 ALK translocated non-small cell lung cancer. This was first-line treatment, so the patient should not have had any prior systemic therapy. Good performance status, patients had to have asymptomatic, treated or untreated CNS mets were permitted. More than one extracranial measurable target lesion should have been there with no prior radiation. Patients were randomized to lorlatinib versus crizotinib into 1:1 randomization, and the stratification factor was the presence of brain mets as well as ethnicity. The primary endpoint was progression-free survival with various other secondary endpoints. So you had 296 patients randomized in the study, 149 to lorlatinib and 147 to crizotinib. They were reasonably well balanced across both the groups, and particularly if you look at brain metastasis as baseline, you had about 30%, about 26-27% in each arm. So this was the primary endpoint. You look at the progression-free survival was not reached in the lorlatinib arm, and 9.3 months in the crizotinib arm. And you look at the hazard ratio, 0.28. That is as good as it gets. 0.28, statistically significant with a confidence interval of 0.19 to 0.41. And you look at a 12-month progression-free rate of 78% in the lorlatinib versus only 39% in the crizotinib. So excellent data, excellent hazard ratios all across. And when you look at the PFS by the investigator, you see a similar picture with a hazard ratio of, again, 0.21, highly statistically significant. The curves are wide apart. Look at the forest plot. Again, everything is in favor of lorlatinib compared to crizotinib, particularly when you look at ethnic origin, Asian and non-Asian, both of them benefit from it. And this is irrespective of their smoking status or age. Looking at the overall response rates, again, more patients in the lorlatinib arm responded to treatment as opposed to crizotinib arm. But more importantly, I think when you look at the median time to response was 1.8 months. So the time to response was pretty quick in both the arms. When you look at the brain mets intracranial overall response, there were more patients who responded with lorlatinib, which is 66%, versus crizotinib. In those patients with measurable or non-measurable brain metastasis as baseline. And when you look at only measurable brain mets at baseline, 82% in lorlatinib arm responded compared to only 23% in the crizotinib arm. Again, highly statistically significant. Duration of response was not evaluable in the lorlatinib arm versus 9.4 months in the crizotinib. So excellent overall intracranial activity. And this is the CNS progression-free curves. Lorlatinib is flat right on top versus crizotinib. Again, lorlatinib not evaluable since it was not reached versus 16 months in the crizotinib. You look at the hazard ratio, 0.07. I mean, I don't think so we get better hazard ratios than these. Overall survival data is not mature enough. Both of them were not evaluable because both of them did not meet the endpoint at the time of this presentation. Hazard ratio of 0.72 with overlapping confidence intervals. Safety, again, there was slightly more toxicity in the lorlatinib arm versus crizotinib arm, but nothing untoward about. Most of the toxicity in lorlatinib we know are more biochemical than physical, which we'll look at. So if you look at the lorlatinib toxicity, it is more hypercholesterolemia, triglyceridemia, some amount of edema and weight gain, but nothing unexpected, nothing that we don't know about, nothing that would preclude a significant dose reduction in our patients. Change of baseline from the global quality of life scores, better improvement with lorlatinib as opposed to crizotinib, but especially after the first few months of starting treatment. So overall, lorlatinib resulted in a statistically significant longer PFS compared to crizotinib, better quality of life, and better intracranial response rates were seen. So I do feel that we should start looking at using lorlatinib in the first-line therapy for all our patients who've got IL translocation non-small cell lung cancer. Comparison with the first-line studies, again, this is not meant for a scientific comparison, but just to give you a brief idea of all the ALK inhibitor studies in first line. We've already heard about the ALEX study. And we look at the CROWN study, you look at the hazard ratios. Hazard ratio in lorlatinib was 0.28. And a CNS response rate was 71%. So I think that is something to take home. When we start looking at a systemic review network analysis, again, lorlatinib trumps the other drugs such as brigatinib, alectinib, or in patients who've been previously untreated with ALK inhibitors or chemotherapy. Again, but network analysis have its own caveats, something we have to keep in mind. NCCN guidelines, the most recent, prefers lorlatinib as a category 1 along with brigatinib and alectinib. So they don't discriminate which one to use. All of the three have category 1 recommendation from NCCN. So we saw this curve from Dr. Rahul Sood in terms of how we've come in terms of ALK inhibition, but we've just put in the last line for alectinib. For just below alectinib, we've put in lorlatinib. Progression-free survival is currently not reached, but hazard ratio of 0.28. So only time will tell with further follow-up whether the progression-free survival will be significantly longer than that of alectinib and second-line lorlatinib combined to trump all of the above. So, but what this clearly tells us that over the past 10 years, we've come a long way in terms of improvement in progression-free survival for our patients with subsequent generations of ALK inhibition. That is it from me. Thank you very much. Over to you. Over to you, Ekta.
Thank you, sir. Thank you so much. And I think you are only going to coordinate the session next.
Yeah, I'll do that. Thank you.
Yeah,
I think we finished on time or much before time. So Dr. Vamshi, I think you have the liberty of an extra 5 minutes if you would like to. But the next session is sponsored by Novartis. And I'd like to welcome Dr. Vamshi Krishna. We all know Dr. Vamshi very well. He's the Director of Medical Oncology at Asian Institute of Oncology in Hyderabad. And he's going to talk to us about the first-line treatment for ALK-positive non-small cell lung cancer. And this session is sponsored by Novartis. Dr. Vamshi, over to you.
Good evening, everyone, and thank you so much, Dr. Vijay. I am not sure I will need the extra 5 minutes, but thank you so much, and I'll also try to complete well in time. So, like all meetings, I believe I'm audible and I'm visually visible.
Yes, Vamshi, yes, you are.
Okay, great, Vijay. So thank you again to the organizers. And as Dr. Vijay said, this is a sponsored session by Novartis. And being a sponsored session, I shall be talking on ceritinib as one of the frontiers in the first line treatment of ALK positive NSCLC. Now, Dr. Vijay has just completed his sponsored talk on lorlatinib. So it's a nice segue into what I will be speaking on, that is ceritinib. Now, ceritinib is something we were very excited about a few years back, and I believe we should still continue to be excited about it. It is still a good drug and it deserves a place in ALK positive NSCLC. Now, these are my disclaimers. We do know that NSCLC is a heterogeneous set of diseases. Probably the only thing that has changed over the last 10 years is the number of these minor mutations that are coming into picture now. And more, as we treat lung adenocarcinomas, we know that the target really defines our treatment. As much as 60 to 70% of patients are going to develop a lung, have a targetable mutation. And certainly one of the most important remains ALK, which is close to 7% of targetable mutations. Again, when we started out, we thought it's around 2 to 3%, but over the years, especially in India, we are regularly seeing around 7 to 10% of ALK mutations among our patients. Now, coming to the testing, by and large, again, a debate that is almost died a natural death. We would have this discussion of should we do a sequential testing, should we do more combined testing, should we just test everything? By and large, with the availability of tests, now both NCCN and ESMO are recommending a broad-based molecular testing to look for the targeted therapies. Now, ESMO still sticks a bit to the traditional view of doing EGFR, BRAF, ALK, ROS1, and NTRK. The NCCN, being more broad in general, has suggested doing a broad-based panel of multiple genes. I think in India, most of us are pretty comfortable now doing a 12-gene panel or a 15-gene panel, or in more cases, a 60 to 80-gene panel to look for our molecular testing. And that's kind of the way it has evolved, most importantly because of the pricing. Other than the challenge benefits, of course, you do know that you could detect all the standard of mutations. You could detect it with a higher sensitivity. You could require less tissue to diagnose it. And of course, the turnaround time has become much more acceptable. There is a challenge in NGS. It still is a cost intensive technique. Sometimes you need some technical challenges. Its accessibility is not there for all centers. The turnaround time remains a challenge, but again, we are now comfortable waiting for a couple of weeks for these reports because of the sheer difference it makes in the outcomes. So Novartis does have its own coupon, which helps in testing, which personally I think is a really good thing they have done. So coming on now to the topic of today, that is ceritinib. Now, the ceritinib story started with the initial ASCENT trials, the first phase 2 trial, then there was a single arm study, and then came this paper. This is 6 years back, it's only 6 years, but it feels like a lifetime ago in context of lung cancer. This was first line ceritinib versus chemotherapy in those patients with ALK rearranged NSCLC. It was a randomized phase 3 study by Castro et al. And this was known as the ASCENT-4 study. Pretty basic model. There was not much complicated. ALK positive, locally advanced metastatic non-squamous, no prior treatment given. 1:1 randomization. Ceritinib, look at the dose, it's 750 versus pemetrexate based treatment. You could use cisplatin or carboplatin. And then the PEM arm could continue maintenance. The ceritinib arm, of course, would continue till the patient had a progression. I really miss such straightforward and simple designs, especially when you come to the multiple hierarchical systems of the latest IO trials. It is nice to sometimes look back at an innocent age when you could simply do a 2-arm study without any complication. Now, what they wanted to look was very simple. As compared to chemotherapy, what was the benefit? And here, look at the median PFS. It is directly doubled. So with chemotherapy, it's around 1. With ceritinib, it goes up to 16.6 months. A very nice separation of curves, starts early, continues and builds up. So a median PFS which is doubled to close to 1.5 years, a hazard ratio of 0.55, a very, very significant p-value. Now, important to also look at other endpoints, the overall response rate of 72.5%, a duration of response of around 24 months, and at least a 24-month initial overall survival of 70%, which was good at the time. But of course, as we'll see later, the OS results have come a little bit of a, I won't say exactly a bad result, but a little bit unsatisfactory. So overall, there was an estimated 45% risk reduction versus chemotherapy, and certainly ceritinib would be a good alternative, would be a much better alternative than chemotherapy. Now, interestingly, when we talk of ALK positive, we keep talking of this Asian patient subgroup, and we keep talking of the brain metastasis. Two subgroups which are really talked about in all ALK trials. So the Asian patient subgroup analysis, which was done separately for ceritinib versus chemotherapy, number of patients were not too many, but still in the two arms, ceritinib versus chemotherapy, again, you started seeing a difference, perhaps a bit later than normal, but a consistent difference which was then maintained. Here, the risk of reduction difference was 34%. Risk of progression or death was 0.66, though it just narrowly missed the confidence interval. Again, we know that the Asian patient subgroup, remember, this is not Indian patients, right? This is Asian patients. We do talk of Asians as being somewhat similar to Indians. I'm not really sure that's the case. I personally feel the Asians, as in the Southeast Asian, the Koreans and the Japanese, are not really similar to Indians. We are more closer to the Western society, but again, we can quibble about this at another point. This is also interesting because we had the Ascend-8 data. Now, the Ascend-8 is a trial which I really recommend Novartis for having done. It's not a usual trial that you see from a MNC. Now, what Ascend-8 did was they actually tried to look at whether we could reduce the dose of ceritinib. Now, you could use 450 milligram once a day with a low-fat meal, 600 milligram with a low-fat meal, or the conventional 750 milligram per day under a fasted state. So the main advantage of this would be that the patient need not fast. Second advantage, you could give a lesser dose. And certainly in terms of the number of tablets the patient has to take, this is a big advantage. So age more than 18 years, treatment naive, ALK positive status confirmed, performance status less than or equal to 2 with stable brain metastasis. There are 3 arms, ceritinib continued. The primary endpoint, now remember, the primary endpoint was not a clinical endpoint. The primary endpoint was a steady state PK of ceritinib 450 and 600 and 750, right? So basically you were not looking at a outcome wise, but you just wanted to see whether the pharmacokinetic profile was similar. As a secondary endpoint, you did look at the overall response rate and the duration of response with a lot of other bunch of secondary endpoints. Now, when they looked at the Kaplan-Meier plot, looking at the duration of response, PFS, and overall survival. Remember, the PFS and overall are not the primary endpoints, but they were compared later on. Now, interestingly, the best results in all the 3 things, that is the duration of response, the PFS, and the OS in the Asian subgroup population, seem to be better with the low-dose ceritinib. So 450 milligram had a better over duration of response. It had a better PFS and finally a better overall survival. So in all the 3 parameters, ceritinib scored over 450 mg, scored over the ceritinib 750 mg. And since this date, again, I'm just revisiting data which a lot of us know. We are actually kind of comfortable just going directly to a 450 mg, but this is the genesis of that data. Again, when they started looking at the actual numbers, look at the overall response rate, 82.8, 78.9, 76.9. Numbers are small, 29, 19, 26, but still it told us that you could use a lower dose of ceritinib in a fed state, no need for fasting, and you would end up getting a good result as well. Median PFS, not estimable here, 21.9 here and 8.2 in the 750. Now, this 8.2 is a little disappointing. Remember, the first SN trial I showed you had a PFS of around 16 months. Now, as compared to that, look at what the previous speaker spoke of, lorlatinib. That was also not estimated. So, you're somewhere going there. The overall survival rate at 3 years, 93% here, 62 and 70.9 in the third group. So again, remember the numbers are small. So I don't think we should really take these as written in stone. However, interesting hypothesis that a smaller dose still did well. And actually by now, I think all of us do take 450 mg as the standard dose. Now, the other important part I told you in the beginning that we keep talking about in ALK is about the brain metastasis. Now, a lot of patients do not have brain metastasis, but 30% of patients could have brain metastasis. This is especially common in ALK rearranged NSCLC, particularly after first generation TKI has been used. So in many patients on crizotinib, around half of them, CNS was actually the primary site of relapse. And therefore, it's good to have a drug which has a high penetrance. Again, when you look at the ASCENT-4 PFS, in patients with brain mets and patients without brain mets, ceritinib achieved a much better PFS. 6.7 versus 10.7 and 8.3 versus 26.3. Again, look at this number. 26.3 is close to 2 years of ceritinib for patients without a brain metastasis. Again, you're edging into territory which was traditionally claimed by alectinib and lorlatinib, but it is still a good response of around 2 years. So there is a high response rate, which was durable in patients with brain metastasis. Again, looking at the patient subgroup by Asian population, again had a better outcome, disease control rate of around 83%. And again, best overall intracranial response was significantly better in the ceritinib arm. Now, the big question, the elephant in the room. Are we going to use ceritinib as a first line, and what do we compare it with? The important thing is that all the other trials, be it lorlatinib or alectinib, have compared their drugs to crizotinib. Do we have a direct trial of ceritinib versus crizotinib? We don't. There is a adjusted indirect comparison. Now, again, it's interesting that you have so many indirect comparisons among the drugs and between the drugs, but be as it may, that's the best data we are going to get. This trial was done by a US group, which also had a Novartis representation in it. So, despite that, I think the data still should be something that we can take it. Now, in this cross-trial comparison, they found that ceritinib had a significantly longer PFS, hazard ratio 0.64. Again, looking at this PFS, 25 months. We are touching the 2 years everywhere when you talk of ceritinib. So again, in adjusted indirect comparison, it was associated with a significantly prolonged PFS. This is the profile 1014 and this is the ASCENT-4, looking at the absolute numbers. Now, overall survival. Remember, at the beginning, I did tell you this was a bit of a cropper. In crizotinib, you had a hazard ratio of 0.76, p-value non-significant, crossing the unity 1.053 with a pretty good numbers, 172 and 171. Remember, this is against chemotherapy. And the reason, obviously, is because of the crossovers. When they looked at the ceritinib data, again, though the overall survival was not estimable here versus 26 months in the chemotherapy arm, which is actually lower than, the crizotinib arm, the hazard ratio still 0.73 and crossing the unity, just missing the significance. So again, ceritinib versus chemotherapy did not really show an overall survival advantage, mainly because of the crossovers. So the PFS is what we got there. Always you are concerned of safety. ASCENT-4 showed there was both in the QOL as well as in the adverse events. It significantly improved the quality of life, significantly prolonged time to deterioration. Now, when you look at the ALK inhibitors, you do have ceritinib, you have crizotinib, you have lorlatinib, you have brigantinib, and you have the alectinib. We could probably leave out brigantinib as we still don't have it in India, but alectinib, ceritinib, crizotinib, and lorlatinib are all available. The approvals have come one after the other. So we have all 4 in India now. Looking at the NCCN guidelines, The preferred drugs remains alectinib, brigatinib, or lorlatinib, all category 1. Interestingly, though they have put serotinib in the other recommended, it still remains a category 1, as is crizotinib. So 4 drugs all could be considered as category 1. What is interesting for me is if you kind of take the serotinib PFS around 24 to 25 months, follow it up with alectinib, and then follow it up with lorlatinib, you are tending to get a quite long PFOS versus lorlatinib alone, followed by, well, only chemotherapy mostly, or alectinib followed by lorlatinib. So all these 3 are kind of comparable. The question really is, would it be easier to give serotinib first, then alectinib, then lorla, or simply use lorla upfront? I don't think we are ever going to get a first-line trial in this. Nor are we going to get a trial of alectinib versus serotinib. I think both lorla and alectinib were tested against crizo, and that itself is quite a big achievement. Beyond that, we just have to rely on these kind of data, which say that, yes, you could still sequence your trials. Again, this is what we know today. Probably after a couple of years, whether this holds true or whether we get new overall survival data is still open to question. Personally, would I still be considering serotinib in today's age? Yes, because number 1, it is definitely cheaper. Number 2, it's a proven drug which works in several situations. If a patient doesn't have brain metastasis, definitely serotinib would still be as part of my thought process. With brain mets, I think you cannot really deny the impact alectinib has had, or lorlatinib has had for that matter. So in the patients, at least without brain metastasis, serotinib remains part of our discussion and definitely remains part of the first line. Of course, we do need to look at the efficacy, because several patients may not survive to receive the second line. So that could be one reason to use a stronger medicine upfront. Dr. Vijay did make that point that you should use your strongest medicine first. It's a question we need to discuss with the patients. No brain mets, definitely this is where I would still be using a drug like serotinib. When you have symptomatic disease, by and large, all the drugs give us a good rapid response. And second line drugs being available at progression gives us a feeling of happiness that, you don't have to jump and give chemo. You can have some other option as well. So to conclude, SN4 trial showed that serotinib has improved PFS and numerically better OS, though the data is still not mature. PFS benefit in both brain mets and non-brain met patients. GI events pretty much manageable, especially with the lower dose of 450 mg. And as I think by now, it's kind of moot to comment about it, but safety and efficacy are pretty much well established in the Indian patient. So thank you, and back to the organizers.
Thank you, Dr. Vamshi, for that excellent talk and a good view of the role of serotinib, and basically a lot of discussion on how to sequence them. And I take your point that when you do look at cost effectiveness, I think you can't beat serotinib in given first line, because at this point in time, lorlatinib and alectinib are prohibitively expensive, and we can sit in meeting rooms and discuss as much as we want to. But I think when it comes to being cost effective healthcare, I think serotinib would certainly trump all of this. So
Dr.
thank
Vijay,
you very much for that.
Dr. Vijay, if I may. Yeah.
Yes,
So Dr. Vamshi, given the fact that you are the 5-star medical oncologist at Hyderabad, and obviously you will not you will treat all the Ambanis and Adanis of Hyderabad. Tomorrow in the clinic, what would you offer to your ALK positive advanced NSCLC patients?
Okay, first of all, I do not treat the Ambanis, and think there are a lot of doctors here who treat them. So second point, as far as treating in first line, see, the way I would go about is still what I told in the meeting. If we have a patient without brain mets, I would discuss serotinib, I would discuss alectinib. A lot of patients, I would tend to push towards alectinib probably, because that has an option of a second line of lorla. Lorla first line, I don't really know what we do in the second line. And the fact remains that though we talk of the mutations, it is not routine practice, and I am at least not doing routinely multiple biopsies to look for the change of the mutation of ALK as of now. So it's serotinib or alectinib for me in the first line. Patients with brain mets, it would probably be one of the newer TKIs.
Thank you. Thanks.
Thank you very much, Dr. Vamshi, for that. I think you did need those extra 5 minutes. Now, coming to the to the next session is going to be by Dr. Niti Raizada. She is the Director of Medical Oncology and Hemato-Oncology at Fortis Hospital, Banagata Road, Bengaluru. And she's going to talk to us about rarer driver mutations, particularly with reference to BRAF and MET exon 14 skipping mutations in non-small cell lung cancer. Over to you, Dr. Niti.
Thanks to the organizers for having invited me today. Thanks so much, Vijay. And thanks Novartis for sponsoring this session. So my topic is targeted treatment, which is specific to BRAF and MET. Well, we have all these drugs available now. And well, it's definitely wonderful times. And this is, I think, our favorite slide when we have a lung session. So there are about 2.2 million new cases across the globe, lung cancer being the second most common cancer and the first most common cause of death. And what we basically need to know is that 87% of all lung carcinomas would have some potentially actionable driver mutation. And this is the interesting area which the entire session today is all about. So what do we have? Well, almost 3% of the patient would have a MET exon 14 skipping mutation. 2.5% may have MET amplification, and almost 5.5% would have BRAF mutation. So these are the three things I would be talking on. And well, Vamsi very nicely illustrated that what is the importance of next-gen sequencing. And yes, we all tend to do larger panels now, at least a 12 or 15 mutation panel, and higher panel if necessary. And definitely the advantage is smaller tissue with faster results and low input of DNA, high sensitivity and specificity, and multiple possibilities. So this is the coupon of Novartis, which Vamsi was speaking about, in which we have results about DNA sequencing and also RNA sequencing. And we have interest here because we are talking about MET with DNA sequencing and BRAF with DNA sequencing. And of course, MET exon 14 skipping mutation with RNA sequencing. So let me start with BRAF V600E mutation, which is called as the typical BRAF mutation. And well, this we all know that BRAF is a serine threonine kinase belonging to the RAS-RAF-MEK pathway. And what it basically does is in tumor cell, the BRAF mutations lead to constitutive activation in the absence of growth factor signaling. BRAF V600E, which I said is the typical BRAF, is the most common activating mutation in cancers. And very commonly we see in melanomas, we see in papillary thyroid cancers, colorectal cancer, and now of course NSCLC, in which almost 5% would have this. Just the V600E is 5%, but if we put BRAF together, it is much higher. So it's a point mutation in the exon 15 of the BRAF gene, where adenine is replaced by thymine. This is actually a very nice slide in which there is a data which we have from China, United States, and Europe, in which they have said that in Europe, almost 5% prevalence of BRAF is noted. And US has the SEER data, which says almost 3% prevalence of BRAF, and China has about 1.7% prevalence. And the outcomes also have been reported, which I'll discuss further. So Chinese data with BRAF mutated specific NSCLC had shown that chemotherapy, the disease control rate was around 79% when pemetrexed was given. When paclitaxel was used as a chemotherapy partner, almost 40% disease control rate, which is almost half of pemetrexed. When vimorafenib, dabrafenib, or dabrafenib along with trametinib was given, there was 100% disease control rate. So this is the remarkable thing which we need to focus on. And in the US BRAF study group, when a targeted therapy was used, overall survival was in the tune of 56 months. I mean, this is remarkable. And then when no targeted therapy was used, the overall survival was in the tune of 27 months, which we normally see. So why do we use the two agent and not single agent? So dabrafenib is an inhibitor of some of the mutated forms of BRAF, including BRAF V600E, as well as the wild type BRAF and the CRAF. Trametinib is a reversible inhibitor of MEK1 and MEK2, and this prevents the activation and kinase activity and works in the downregulation pathway. When we bind BRAF and MEK inhibitors in the targeted sequence, we know that they act at different level and therefore are involved in oncogenic signaling and causing cell cycle arrest. What we know is this: when dabrafenib is given as a single therapy, like only a monotherapy, it leads to actually a paradoxical activation of the downstream effectors, and therefore actually can lead to tumor progression. And that's probably the reason trametinib should be added in all cases, and not dabrafenib alone is not recommended. So this was the landmark study, and this was also the study which led to FDA approval, although it was a very small study. And the background of the study was that there were 3 cohorts, and the cohort A, which established the role of BRAF, was a phase 2 BRF 113928. The study design was 3 cohorts, and the first cohort had 60 patients in stage 1, stage 2, and then expansion cohort, in which all good performance status, that is 0, 1, and 2, were used, with who had already been treated with platinum therapy. So they were given only dabrafenib, that is 150 milligram twice a day, and which was an escalation arm. The cohort B, which had 40 patients, which actually established the use of dabrafenib along with trametinib, was again patients who had 1 to 3 prior lines of therapy and at least 1 line of platinum-based therapy, in which dabrafenib was given as 150 milligram twice a day, and trametinib was given as 2 milligram once a day. So this was again a dose escalation arm, in which stage 1 had 20 cases, stage 2 had again 20 cases, and overall 57 cases were used. So patient demographics and characteristics were matched. Most of the patients were more than 60 years, median age being 64. The most common metastatic site was lymph node, and in the treatment naive patient, and also in the pre-treated cases. The treatment included chemotherapy, immunotherapy, and also biologic therapy. So what happened in the dabrafenib trametinib arm, who had been pre-treated and who were treatment naive? In both the cases, the overall response rate was 69% in the pre-treated arm and 64% in the treatment naive arm. The median duration of response was about 10 months in both the arms, that is 9.8 months and 10.2 months. The median progression-free survival was also very similar in both the arms, that is 10.2 months and 10.8 months. And the median overall survival was 18.2 months and 17.3 months. All these results were very poor in the dabrafenib monotherapy arm, that is the single agent arm in cohort A. This led to basically incorporating dabrafenib in the NCCN and the ESMO guidelines. And now in the first line setting, we could either give dabrafenib along with trametinib or vimbrafenib in certain circumstances, as per both NCCN and ESMO. And as I stated, that this was the sum with the data cutoff being June of 2019. So we have these results for almost 2 years now, with the overall response rate in the combination arm of 68%, the median progression-free survival of 10.2 months, median overall survival of 1.5 years, that is 18.2 months. And this led to the granting of permission on June 22nd, 2017. But the final results were published in 2019 in Annals of Oncology. So next I'll be talking about capmatinib, which has been recently introduced by Novartis in the market, which acts on MET exon 14 mutation. So what exactly is the MET oncogenic driver? Well, when we talk about its practical application, we could be talking about MET kinase domain mutation. It could be MET amplification. It could be MET fusions, or it could be skipping mutation. So all of this requires a wider panel, a good sequencing method in which you could do RT-PCR and genomic sequencing, or a whole exome sequencing, or preferably a hybrid capture NGS. And according to FDA, the approved panel is Foundation 1. And what are the clinical characteristics of MET exon 14 NSCLC? Well, they are seen in almost 3% of all NSCLC, more common in female population than in males, which is very similar to most of the other specific biomarkers as well. The median age of presentation is 72.5 years, which is significantly higher than the average age of lung cancer presentation. We also note that most of the histology is adenocarcinoma. There's no clear association of smoking history, and it definitely presents with more aggressive disease and also aggressive histologies. And most commonly, as we see in clinical practice, sarcomatoid features will be seen in most of these patients. BRAF mutation will have micropapillary features on pathology. So this was the results we had until the approval of capmatinib, that if we had MET exon 14 skipping mutation, it was associated with worse prognosis. And as you can see that in the second Kaplan-Meier curve, wild type, which did not have MET, had a significant survival advantage versus the patient who had MET skipping mutation. And this happened when targeted therapy was introduced in stage 4 cases, which was MET specific. And until now, what we had was crizotinib and cabozantinib, but now we have capmatinib. And as soon as the drug changed from chemotherapy to targeted therapy, the median overall survival improved from 8.1 months to 24.6 months. This was again a remarkable increase. And this was the comparison which was there when we had crizotinib as the only non-specific MET targeted drug. In this study as well, when crizotinib was given, the overall response rate was in the tune of 32%, which was less, but almost double as compared to chemotherapy or immunotherapy. And we have now almost finished 1.5 or probably more than that years with capmatinib available. And still, I mean, it took a while to have it in our country. So what exactly is capmatinib? It's a highly selective MET inhibitor, ATP competitive, highly potent, reversible inhibitor of MET. The other inhibitors available are capmatinib. Besides capmatinib is savolitinib, tepotinib, which we don't have until now, but commonly used in Japan and Korea. And of course, we have cabozantinib as well, which has again come in market only in the past 3.5-4 months. And then crizotinib, which we all were using all this while when we had a MET drug. So as Vamshi said, the complex study designs which we have, and this is just the right example of that. Geometry Mono 1 was a phase 2 study design with actually not a very large number of patients. It had 373 patients with 7 cohorts. Actually 8 cohorts, because one cohort had 2 parts in it. And all the patients more than 18 years of age of any histology, whether it was adenocarcinoma, sarcomatoid type, or it was squamous cell carcinoma, who were EGFR and ALK wild type and had MET dysregulation by central pathology in good performance status with one measurable disease at least. And the drug dose was 400 milligram given twice a day. Again, there were 2 arms with given in fed state or not fed state. This was a multi-cohort arm, but 2 stratification criteria was whether previous treatment was given or not, or whether it was MET dysregulation versus MET mutations. So these were the results in which I'll talk about treatment naive patients and treatment pre-treated cases. So cohort 4 and cohort 6 was the arm of pre-treated cases, and most of the patients had received at least 1 line of platinum-containing chemotherapy. Some had received 2nd line and 3rd line chemotherapy as well. And what were the results? When a treatment naive cohort was taken, that is 5B and 7, the overall response rate was 68%. The median progression-free survival was 12.4 months. The median overall survival was 20.8 months. And the median duration of response was 12 months. So this was much better as compared to chemotherapy alone, when the ORR was only about 17%. So 17% became 68%. And of course, the PFS and OS also improved. When pre-treated cohorts were taken, that is 4 and 6, the ORR was 40% with a disease control rate of about 78%. So in summary, Geometry Mono 1 was capmatinib trial with 400 milligram twice a day with about 373 patients. The stratification arm were MET exon 14 mutated versus MET amplified arm. The primary endpoint was ORR. So in MET skipping mutation, which are actually the specific mutations for capmatinib, in treatment naive patient, the ORR was about 68%, with the median duration of response about 12.6 months. In the pre-treated arm, the overall response rate was around 40%, and the median duration of response was 9.7%. Now, the second part is actually alarming. MET amplification with less copy numbers, that is when the copy number were less than 10, the response rate was only about 10%, which was 70% in skipping mutation arm. And when the amplification copy number was greater than 10, the overall response rate was 30% in pre-treated cases and 40% in treatment naive arm. So also we need to know that it has very high activity in brain metastasis. In this study, only 13 patients had evaluable brain mets.
Hello, ma'am. You have 1 minute to conclude your talk, ma'am, please.
Yes, ma'am. Yes. And we found that intracranial responses were as fast as the extracranial responses. The most common side effect noted was peripheral edema, which was seen in around 43% of patients. And besides GI side effect like nausea and vomiting, which was seen in about 35% patients. So in summary, we know that this is a very specific, highly specific drug for NSCLC expressing MET exon 14 with good intracranial and extracranial responses with very manageable side effect profile. With this, I end my talk. Thanks so much.
Thank you very much, Dr. Neeti, for that excellent talk. I think we don't do justice by not doing BRAF and MET upfront. I think we're still stuck on EGFR across and PDL1. And I think your talk pretty much clearly tells us that we really need to be doing NGS in virtually all our patients with lung cancer. So just one question before we meet on. So Dr. Neeti, do you regularly do NGS in your practice for lung cancer patients, or are you still doing like us EGFR across and then reflex testing after that?
No, Vijay, we actually in our hospital, SRL is a very nice 15 gene panel.
Okay.
We commonly use that and with good tags. So we commonly use
what is your turnaround time for those?
And it takes about 14 days.
14 days to come. Okay, it's not
By
too
the
bad.
time it's had chemotherapy, yes.
Yeah.
And also I mean, in this process, in the past few years, we have surprisingly, I mean, we have started using it only for the past 2 years. We have found so many patients with RET, MET, and I mean, ERBB2, ERB2. Surprisingly, I mean, I think when we do all these, we find them very frequently and then we are stuck. Because at least ERB2, I mean, I think we still don't know what are the first 2 lines we should be using. And when we had MET gene positive, but we didn't have the drug and we were using only crizotinib. Cabozantinib came around the same time and capmatinib is available. We tried few patients on compassionate ground as well, but it takes a long time and patients don't do so well.
No, fair enough. We did that for one of the RET patients. It took us 3 months to get the drugs. No. Thank you for that. I think we should all go down this route of doing NGS for the vast majority of our patients. Thank you very much, Dr. Neeti, for that excellent session. So we'll move on to the next session. I think there's a slight change in the program. We'll move on to the Dr. Prasad Narayan's session sponsored by CIPLA, and then come back to Lily's session after that. So the next session will be by Dr. Prasad Narayan. He's a senior consultant and director of medical oncology at Site Care Hospitals, Bengaluru, and he's going to talk about the role of targeted therapy, immunotherapy in early stage lung cancer. I think this is a very hot topic, and a lot of recent data has come on the role of both targeted therapy as well as immunotherapy in early stage lung cancer, more as an adjuvant therapy. So Dr. Prasad Narayan's talk.
Good evening. So in the next 20 minutes or so, my job for the day is to discuss about the role of targeted therapy, immunotherapy in early stage lung cancer. So when we talk about lung cancer, we know that it is one of the most common cancers, which is having high mortality all over the world, and India is no exception here. Third most common cancer causing death in India. Number 1 cancer in terms of incidence and death across the world. And in such a situation, we should always look at the curative intent treatment patients. So 30% of the patients present with resectable disease, which is less actually, 70% presenting in advanced stage. But still, if we can do something for those 30%, we can make a difference. And more so because with the present available treatment, which is in the early stage, which is surgery followed by chemotherapy, we cure about 45% of the patients in stage 1B. That is a very less percentage, and the number of patients presenting in this stage is also less. And in stage 2 and 3, it is even the recurrence rates are much higher, 62 and 76%. So with this background, when we see that the advances which has happened in the advanced stage in lung cancer, we have a plethora of mutation specific treatments which are available in EGFR, ALK, and with the advent of immunotherapy, we are treating advanced lung cancers much better than what we used to do some time back. So Are we doing the same in early stage cancers also? So maybe 10 years ago, if you see the treatment paradigm in early stage lung cancer, stage 1 to 3 is surgery or surgery followed by platinum doublet chemotherapy or chemoradiation. How is it changing? Have we got any data about targeted therapy, specifically the EGFR directed therapies here and the checkpoint inhibitors in this scenario? So the talk will have, I will present 4 data sets actually. One is the adjuvant anti-EGFR therapy in EGFR mutant patients, adjuvant immunotherapy with radiation, already approved treatment, adjuvant immunotherapy after surgery, and the neoadjuvant immunotherapy data. So let us talk about the EGFR story first. We know that the EGFR mutation information has made a huge difference in advanced stage lung cancer. What about early stages? We were all excited about these trials actually with erlotinib and gefitinib in different scenarios in EGFR mutant patients. All of them failed flat. And then this study came, the ADAURA study, the most effective anti-EGFR therapy which we have now, the osimertinib, in attempt to see whether after complete resection in patients with stage 1B to 3A will benefit by osimertinib or not. So when you see the assumed DFS hazard ratio was 0.7 for the study, which is a modest, expectation, I would say. And the usual stratification criteria, stage, the type of mutation, race, etc. And well-balanced study, nothing much to choose there. The incidence of the early stages or the late stages equal among both groups. The type of mutation also similar. Prior adjuvant chemotherapy also around 55% of the patients got in both the groups. So this is what the study results are. The primary endpoint was DFS in stage 2 and stage 3A specifically. The hazard ratio here is 0.17, which is much better than what they expected. And the study is definitely a positive study. The curves are widely separated and adjuvant osimertinib significantly prolonged DFS versus placebo. What about if you take the all comers? That was the secondary endpoint, including the stage 1B group also. Here also there is a benefit. The hazard ratio is 0.21 and osimertinib is, regardless of whether it is stage 1B, 2 or 3A, improves the DFS in EGFR mutant patients post-surgery. So no specific subgroup we can isolate saying that they will not benefit elderly based on sex or the race or the stage or the type of the EGFR mutation and whether they received adjuvant chemotherapy or not. All the patients benefited with osimertinib with similar hazard ratio and similar benefit actually. This is the stage-wise distribution and there is nothing to say much about this. And the overall survival data is still not mature. So when we talk about this, the next thing to see is about the adverse events. The adverse events, we know osimertinib is a good drug and this trial was no exception. Grade 3, 4, hardly any high percentage of adverse events. The main thing was the GI side effects, which is manageable. So the conclusion, osimertinib, the first anti-EGFR therapy to improve DFS in stage 1B, 2 or 3A EGFR mutant NSCLC. Very effective treatment, no new safety signals and should be the standard of care. So that's about the EGFR in early stage. Let us go to the immune checkpoint inhibitor based therapy in early stage. We will first look at the neoadjuvant therapy data. So this is the Checkmate 816 study, which looked at chemotherapy plus nivolumab versus chemotherapy alone in stage 1B to 3A, similar group as the osimertinib study. This specifically patients shouldn't have had any sensitizing EGFR mutation or ALK alterations. Stratification was based on the PDL1 score, which was tested with the 28.8 actually. And the study had almost 350 patients randomized into 2 arms. Patients received underwent radiological restaging followed by surgery within 6 weeks post-treatment. So now we have another new endpoint, that is the immune-related pathological response criteria. I think we are learning new and new things, and I don't know where we are going actually in terms of how many things we should learn about new pathology. New things in pathology. So the the primary endpoint was a pathological response in the patients who received chemotherapy plus the nivolumab. So well-balanced study. The PDL1 score more than 1 was seen in a significant number of patients. Actually, less than 1% was only in 25% of the patients. And it was, if you see the patients who received neoadjuvant therapy, almost everybody received, completed all cycles, 94% in the immunotherapy plus chemo arm, 85% in the chemotherapy arm. Why they did not receive? Because the number of progressive disease were more in the chemotherapy arm. It was 9 versus 7. Adverse events were equally balanced. Some other indications, some other reasons why the patients did not receive surgery were also there. That is there in most of the neoadjuvant studies. The type of surgery, lobectomy versus pneumonectomy, nothing much to talk about that. R0 resection rates were 83 versus 78. Now coming to the primary endpoint, this is where it is really interesting to see that we had around 24% of lung cancer patients getting a pathological CR, that is T0N0YP, in if you give new immunotherapy with chemotherapy in this group versus almost nothing in the chemotherapy arm, because we have never thought about pathological CR in lung cancer. At least I have not thought about before the study came. Number of patients who underwent resection, if you take them specifically, the path CR rates are 30.5, which is much impressive actually. And there was another arm in this study. I will not talk about that. The data is presented only for the chemo plus immuno arm. The immuno-only arm also had a path CR rate of 20.4. So the path CR was the primary endpoint, and regardless of which group, regardless of the PDL1 score, there was benefit by adding nivolumab. Overall response rates were not much different. See, interestingly, it was 31 versus 24, but path CR rates were different. So treatment-related adverse events were seen more in the patients who got both the combination, and not much to choose actually. There are grade 3-4 toxicities, not much different between the two arms. The summary, the path CR as a primary endpoint, if you are looking at this study, has proven that path CR rate we can achieve in early stage lung cancer by giving chemotherapy with nivolumab. So first phase 3 trial demonstrating benefit of neoadjuvant immunotherapy plus chemo for resectable NSCLC. The result, now we have all the other immunotherapy drugs which we know in different combinations being tried in the neoadjuvant setting. For want of time, I will not go into details of this slide. There is another study which has looked at single agent immunotherapy as that is with atezolizumab in the same group of patients and looked for surgical resection. Primary endpoint again being a major pathological response, and this study also had a good major pathological response of 21% with just single agent immunotherapy. So these two studies have actually increased the interest in giving neoadjuvant immunotherapy either alone or with chemotherapy in resectable lung cancer. Let us see whether there is any data on adjuvant immunotherapy after surgery. This is the IMpower 10 study. Again, atezolizumab as a single agent after the patient gets the surgery done and the adjuvant chemotherapy, atezolizumab was given for 16 cycles. Very busy slide. It doesn't give us much information from this. So the most important thing, if you see, the actual primary endpoint was in PDL1 score more than or equal to 1%. There was some difference, but it is not as wide as the other studies which we have seen. But some benefit of adding immunotherapy is seen in this group of patients in the adjuvant setting if the PDL1 score is more than or equal to 1%. Across subgroups, if you see, I would say we should see at this one, which was the, if you take all the randomized patients, that is regardless of the PDL1 score, this was a negative study. If you take for all the randomized patients, regardless of PDL1 score, the hazard ratio did not meet the primary objective. So DFS in all randomized patients, if you take, it is not that significant to make it a standard of care. Early overall survival, I think the data is immature. The curves are very close to each other. There is some tinge of benefit which is seen in the patients who have a PDL1 score of more than or equal to 1. So there we have other studies which are looking at the same question in different forms, maybe with or without chemotherapy. let us look at the other study. This is the already this study is approved, so I will not talk much about this actually. This is another group where we have given curative intent chemoradiation followed by immunotherapy with durvalumab with a primary endpoint of PFS and OS, and it met its primary endpoint. 5-year overall survival with durvalumab was 43% versus 33% without it. So it's an approved treatment. Another role of immunotherapy in the post-chemo radiation scenario in early stage lung cancer. So let us look at the data in full. So the immunotherapy data says that adjuvant durvalumab post-CTRT improves outcomes and is already a standard of care in this group of patients. Adding nivolumab to neoadjuvant chemotherapy increases radiographic response and PAT-CR rates without increasing toxicity. Early data, we don't have too much data on whether this will translate into a DFS or OS benefit, which is what we look in early stage cancers. The adjuvant ATISO data after surgery improves DFS in patients with PD-L1 positive, but if you take all comers there, the study did not meet its primary endpoint. So immunotherapy will likely become a mainstay of perioperative management in clinical stage 2 to 3 lung cancer in near future. The interesting thing will be, what are we going to take away? Are we going to look at only the patients who are EGFR negative, because now osimertinib has become the standard of care post-resection in that group? Or should we disregard the role of CTRT followed by durvalumab and give neoadjuvant chemo plus immunotherapy followed by surgery? All these, I think, are points to be discussed. Maybe in the panel discussion, we can take up that. That's it from my side. Thanks a lot.
Thank you, Dr. Prasad, for that excellent talk. I think this is a recorded session. I'm not sure if it's available to take any questions, but we'll, I think, move on because we have another.
Vijay, I have 2 comments on that.
Yes,
previous thing. First of all, a fantastic presentation, and the second thing is that if you look at the Empower 010 graph properly, the major benefit was there in PD-L1 more than 50%. They have not reported the results of PD-L1 1 to 49%. So probably it was the more than 50% which was driving all these results.
Quickly, but instead of talking about all the.
No, I think.
Hi, Ulas.
Hi, Ullas, please carry on. Please carry on. Now, actually, you're absolutely right. I think, and as with all immunotherapy data, and we see this across the board, that higher the PD-L1 may be skewing your survival data
the second thing is, in my opinion, if you have an EGFR positive lung cancer in first, second, third stage, no point in giving immunotherapy. You have to give osimertinib with the subset analysis also, and it's going to be a battle of subset analysis in the next 20 minutes. With
subset analysis, not powered subset analysis is different from powered subset analysis. But yes. I take your point that given
non-small cell lung cancer early stage, I think osimertinib is the way to go.
Absolutely, I agree with you, and I think all of us agree that both the ADAURA as well as the Pacific, I think there is no question on that. The issue will come with regards to perioperative chemoimmunotherapy, whether that will downstage treatments in the future. Thank you. So we have an exciting session going forward. This session is sponsored by Eli Lilly, and we have a very exciting debate and 2 very eminent speakers, Dr. Ullas Batra, who is a senior consultant medical oncologist, who is the chief of thoracic medical services as Rajiv Gandhi in Delhi. And we have Dr. TP Sahu, who is a senior consultant medical oncologist at Silveram Bhopal, and our debate is essentially third generation TKI versus first generation TKI combinations in EGFR mutated lung cancer. Now, this is a very important topic, and this is one of the reasons I picked this up, is that this is a real life problem, that when you have a patient who comes to the clinic, you have 2 very good options. Now, no one is really talking about first generation TKI alone or second generation TKI. We either have options of giving them third generation TKI or first generation TKI. There may be some cost benefit, but there is also excellent data on that, and there is absolutely no head-to-head comparison. So I thought this will be an excellent debate, and we've been fortunate to get 2 excellent speakers to do this debate. So over to you, Dr. Ullas, on the role of third generation TKI.
Okay, thank you. It's after a long time, Vijay, that I am debating. But the only thing is that I have learned is that I should actually check my emails much more carefully. Before today, Sahu, when you called me up, I didn't realize I was debating against you. So then I have stopped all my OPDs, and all that I have done in the last 5 hours is to look at your photographs on the internet. So my confessions before I begin the debate is about the art of oncology and science of oncology. Most of the people know, I mean, Kumar and Kumar, Senthil, me and Sahu are from the same college. And whatever little science and art of oncology I've learned is I owe a lot to them. And what Dr. T.B. Sahu, my esteemed senior, has told me in the first day when I joined oncology was do no harm. I still remember Sahu was telling our patients, hey, you should always be very, very careful with them and avoid a remedy that is worse than the disease. Unfortunately, Dr. Sahu, I think I'll need to give you a lesson in that only today. So I'm going to speak for third generation TKIs today. And my first reactions, I've been reading a book called as Ikigai. That's a Japanese secret for a long and happy life. And it basically says, you put that person at the center and decide about what you love, what you are good at, what you are paid for, and stuff like that. So my first reaction when I see a stage 4 lung cancer patient is basically about understanding what a lung cancer patient, actually stage 4 lung cancer patient, basically wants. What the patient basically wants is a good drug, which basically has an increased PFS and OS. It crosses the blood-brain barrier. It should be oral, ease of administration, and probably if it is, good quality of life. That is what I would want if my attendant was basically had a stage 4 lung cancer. With this in mind, let's go and look at the two data. I'm going to speak for third generation and Sahu is going to speak for combination. Let's look at the osimertinib data. All of us have seen the data. This was a double-blind study design, not the open label which other trials are. The PFS was the first primary endpoint actually over here. These are the 6 goals that I have written: PFS, ORR, increased OS, good CNS, good quality of life, and please avoid chemotherapy. That is all that is there. So let's look at the primary endpoint. And today I'm going to give you some lesson in statistics also. Let's look at what the PFS, the primary endpoint was PFS, and look at the early separation of curves over here. The moment you start giving them osimertinib versus gefitinib, the people start to be improving. This basically means that osimertinib is a better drug and lower incidence of resistance mutation to osimertinib. Also, please, Dr. Sahu, I know you're going to make a lot of hue and cry about L858R and Asian subgroup. When it was powered for the for the PFS, that was the primary endpoint, there was no difference whatsoever. So there was a longer PFS, absolutely okay. Was there a longer OS? Definitely there was a longer OS. Again, this was statistically significant. Now, Dr. Sahu, please remember this: increased OR, increased overall survival. The numerical value of overall survival will come to later. Now, what about the CNS activity? We all know the CNS activity of osimertinib is fantastic. Now, osimertinib demonstrated a superior systemic PFS benefit, whether you had CNS disease or whether you not had CNS disease. And if it obviously responds to CNS, the incidence of radiotherapy to the brain actually comes down. What about the patterns of relapse, CNS versus extra CNS? The CNS patterns of relapse are actually lesser in the FLORA trial. And I do not want to even show Dr. Sahu about the ADAURA trial because, hardly 1% of people relapse in the CNS. So that's also a very, very, very good thing. Now, what about osimertinib in leptomeningeal metastasis? I'm sure Sahu has a better experience than me. And this was a Bloom study, which basically said, that you had a response of 62%, and the overall response was around 41%. The median duration of response was around 8.3 months. Leptomeningeal mets, ask any oncologist, and I'm sure Dr. Sahu will tell, it is a bad news for the patient. It is almost like a death sentence. Osimertinib, single drug, giving you a DOR of 8.3 months is absolutely fantastic. Sahu will say, this is all happening in the West. Where is osimertinib, our data? So I showed him, let him show him my data. This was the data which was presented in our this thing. It was published at ASCO, and we had given it to 12 patients actually, and our patients, the median leptomeningeal PFS and OS was not reached. The response rates were around 60 to 70%, and this is actually APNA data, I'm sure, which we are all very proud about. So the 4 boxes tick. Now, what about the grade 3 adverse events? You had a 38% grade 3 adverse event. I'm sure Dr. Sahu is going to show you this. Frequency of dose reduction 4%, treatment discontinuation 13%. Fantastic. But look at what were the adverse events. You had diarrhea, you had rash or acne. I mean, come on, diarrhea, rash or acne, decreased appetite, a grade 3 side effect. I'm sure we have given much more toxic chemotherapies and transplants than this, and oral medicine can easily surpass from there. Quality of life of both the oncologist and the patient is much more better if you give an oral tablet, and obviously the patient is getting much benefit. Now, what about the time to subsequent therapies? Time to first subsequent therapy is 26 months. Time to next subsequent therapy is 31 months, which is also much higher in the osimertinib arm. So this is what my, this is what the osimertinib will be asking at this time. What more do you want from me? And Dr. Sahu, bachche ki jaan loge kya? But I'm sure you will. And the bacha actually right now is me. But this is my point of view. And this is what oncology you have taught me. Now, let's listen to the other side of the debate, which Dr. Sahu will come. And this is not the other side of the story that is important. Look at the ones, questions everything. We will question everything. We belong to a ex-party, election season hai. Kuch bhi bol do, log maan lenge usko. This is what Sahu wants to believe. If you are alone, you obviously want a partner with this. And Sahu basically wants a combo offer. Maybe Dr. Sahu is by and large having a middle life crisis where he wants a good partner actually over there. So this is what Dr. Sahu wants. We'll question everything over here. This is what Dr. Sahu will show. Three trials, fantastic trials. One was the Japanese study, 53 months survival, one is the data which is very close to my heart. Honestly, didn't want to criticize this data for love and affection towards Kumar and Noah, but I'll have to do it. And this was the Chinese study which Dr. Sahu will show, which showed some advantages. So this is what Dr. Sahu wants us to see. The combination arm is exactly going to be, like a honeymoon lasting forever. And this is what Dr. Sahu also, look at Dr. Sahu alone and look at Dr. Sahu all shaved up in company of a good combination partner. But unfortunately, Dr. Sahu, that's not how it works. You are telling us all the stories about what happens pre-Valentine's Day. I will show you stories in the Valentine's week about what happens post-Valentine's Day. Let's welcome to reality. Let's analyze the data. I will show you the first data, 52-month survival, the NEJ009 study. Gefitinib alone versus gefitinib plus chemotherapy for non-small cell lung cancer. Please remember, now look at this, Dr. Sahu. What are the primary endpoints? PFS1, PFS2, and OS. This was the primary endpoint. If your statistical hierarchical design did not say PFS1, PFS2 was superior, your OS could not actually be reached over there. And following gefitinib, patients all got pemetrexed cisplatin. So either you got gefitinib, pemetrexed cisplatin, or you got gefitinib followed by pemetrexed cisplatin. What happened? This is what Sahu will show you, 20.39 versus 11.17. What Dr. Sahu will not show you here is that if you give gefitinib followed by pemetrexed cisplatin, by and large the same amount of benefit you can get. This is the ASCO 2021 presentation, Dr. Sahu. Look at the toxicity profile. I mean, just imagine how many patients. I showed you 38% people with osimertinib may get some toxicity profile. Look at the toxicity profile. 66% of patients are actually getting toxicity profile. And what are the toxicities? Leukopenia, neutropenia, anemia, thrombocytopenia, liver dysfunction. These are not your simple toxicities such as liver dysfunction, etc. So this definitely is toxic. What about the global quality of life? While you are taking chemotherapy, Dr. Sahu, look at this. Your quality of life actually decreases initially in the chemo upfront arm. Now, this is my punchline, Dr. Sahu, which I read today after you told me that you are debating against me. This was the ASCO 2021 presentation, which says updated analysis of NEJ009. And I'll read it for you. Busy slide. Please read it properly. And maybe you will not debate after that. 345 patients were assigned this. At the latest data cutoff, there was no significant difference in overall survival. No significant difference. And you will show me the subset analysis HR data 0.82 and the confidence interval is 1.06. So this trial was a negative trial as far as the OS and the PFS2 was concerned. Again, you will show me the following subset analysis 0.5, 0.77, 0.82. Please see these also, Dr. Sahu. I am sure that is what you would be wondering about. Ye kya hua? Kaise hua? Kab hua? So I will tell you some more things, Dr. Sahu, which will happen. you would be very fond of showing me some subset analysis data about Asian subgroup and non-Asian subgroups and stuff like that. Now, this is the subgroup analysis of your best data, that is from Japanese. Females, this does not benefit. Your chemo combination, this does not benefit. HR of 1. Non-smokers, it actually doesn't benefit. Also look at the EGFR 19, 18. All the confidence intervals are crossing the unity. So please be wary about this subset analysis of an underpowered analysis. Actually, subset analysis of OS can be seen over here because it's a primary endpoint. So please remember this, Dr. Sahu. Do not show me unplanned subset analysis of the FLORA data. Now let me come. Oh, what did the authors say actually? The authors actually said in their own paper that patients with poor PS with symptomatic CNS mets should actually get osimertinib because they may not get treatment over there. And they also said the OS benefit requires further validation. So your overall survival, Dr. Sahu, is not increased in the NEG 009 trial. And this is straight from the horse's mouth. Now, this is what was the TMS data. And again, before I begin criticizing this data, huge round of congrats and appreciation for Kumar and Vinita, because they did something that I'm very dying to do something. But for the purpose of debate and for the purpose of science, I have to do this. So look at this, 712 patients were assessed, only 350 patients were randomized. Koi baat nahi, it is India, sab chalta hai. Now look at this, if you look over here, only 80% patients completed 4 cycles of pemetrexed carboplatin. 14% patient received 3 cycles, 5% patient received 2 cycles, and 7% received only 1 cycle. 13% patient required dose reduction because of toxicity. 39% patient had dose delays. I mean, what exactly are we trying to do by giving them chemotherapy and this? Now, comparing all toxicities, 38% osimertinib, 75% Japanese study. Here we have 75% patients who had a grade 3 toxicity. And again, if you see the clinically significant toxicities over here were seen in 50% of patients actually. I mean, I'm sure Dr. Sahu, you'll be saying it is hard. Now look at the CNS data. I showed you 15 months of PFS data. Look at how many people have got whole brain radiotherapy in this. 13% people in the Jeff plus C arm actually have got the radiotherapy also in this, which is not a very nice thing. And I'm sure this is what Dr. Sahu would actually be doing right now. So this was the letter to the editor by one of the people who criticized. They said the data was assessed not by an independent observer. It was actually assessed by the thoracic radiologist only, which is also not a very nice thing, because all this data should have been assessed by a blinded independent central radiological review. This is not what I say. This is what Tony Mock says. Now look at the positive HR. The control arm actually underperformed. Your median OS was only 17 months. The median PFS was only 8 months. I did a bit of calculations. If your median PFS in the Indian study was 11.9 months, your HR value, Dr. Sahu, would have been only 0.8. The quality of life data was not there. There was more toxicities. Very few people got osimertinib. You didn't ask the patient what they want, and the cost effectiveness was lacking at that particular time. Now, what about the addition of anti-angiogenics? I don't want to spend much time. Look at this curve, Dr. Sahu. Again, OS is not benefit. When you talk of FLORA, when you talk of when you talk of other drugs, you want OS. Here, you don't. Are you happy with only a PFS advantage? Again, look at the toxicities of NEJ 0026 study. There was no OS benefit. 91% patient had a grade 3 or grade 4 event. Whom are we trying to impress by giving drugs like this? What about the relay study? The PFS is more. I know you will tell me about the L858R and the DEL19 story and everything, but no OS benefit as yet. The CNS mets were included over here, which are 20% of your patients. Safety profile is of concern again. And Dr. Sahu, I'm sure you're going to tell me about the cost. Have you ever calculated the cost of erlotinib plus ramucirumab? Unless or until Lilly gives it for free and patient have to come twice a week over here, it's not really worth coming over. Again, Dr. Sahu, I'd like to remember you, your cure cannot be worse than the disease, and this is one you should do no harm. Let's do a cross-trial comparison. PFS increased in everyone. OS increased only basically in the FLORA. The TMS, the KN regimen, it has not been reported as yet. Brain penetration, yes for osimertinib. Toxicity profile, better. QOL data, better. What more do you want? So, what will Dr. Sahu debate today? He will tell me about the subset analysis. He will show me the he will show me the EGFR and the Asian study. But again, that wasn't secondary analysis. That was not a primary analysis. And again, as a secondary endpoint, the study was not powered for the same. Subset analysis will be of a secondary endpoint, Dr. Sahu. I am sure, tum karo to alag or hum kare to galat. That is not very nice over there. This is a Chinese flora study. Again, thank you, Dr. Sahu, for telling me about the Chinese, the Asian subgroup. Again, this study basically showed that the median PFS in the Chinese patients and the non-Chinese patients were by and large the same as the global flora group. So I don't think Asians behave typically different from a non-Asian patients. Dr. Sahu will also tell me what after osimertinib, the disease is bad, this is everything. So Sahu, if you have any patient or anybody is any patient, we have 4 trials going on right now for patients with post-osimertinib. We can give them capmatinib, we can give them savolitinib, we can actually give them combination of amivantamab, lazertinib, and chemo versus chemo alone. And these trials are currently recruiting not only at RGCI, at other centers also. He will now then tell you, rare mutations. The Vinita studies also took people with rare mutations, but again, so has osimertinib been tried in rare mutations. And again, if you read over here, there is a favorable activity with manageable toxicity profile with that. And I'm sure this is what Dr. Sahu will say, or Vijay will say, ki bas kar pagle rolaega kya. But I thought one more point, last point, cost. This is something which I have just taken from my medical oncology group, and this is what Dr. Parekh says, How many times do we hear comments in the oncology meeting that my patient cannot afford this drug, that drug, but that's not how the science really works. This is what exactly the editors had to say after the Vinita paper, that patient without access to OC, maybe this can be tried. But patients who have got to access to osimertinib, the data are provocative, but they have not yet demonstrated superiority. Now let's look at the Japanese guidelines. Japanese had a highest number of 52 months, and look at them. 93% of them will recommend osimertinib. Only 18% will recommend geftinib plus chemotherapy. 4% will only give them geftinib plus anti-angiogenic agents. What is the first line treatment for ECOG PS2? Japanese study. 86% of patients will say some amount of oral TKIs we will give. What about the guidelines? We will quote NCCN guidelines. I looked hard, and I looked at osimertinib. I could not actually find a chemotherapy plus osimertinib in this. What about the Pan-Asian guidelines? This also says osimertinib is the best, and this is the best. This is the best. Guys, small print, sorry. This is the Indian guidelines, and which again says osimertinib is the preferred option. And I looked at the names over here, Kumar Prabhash, Amish Vora, Sevanti. Then there's a name called Tarini Prasad Sahu, which actually just comes before me. Tarini Prasad Sahu in practice agrees that you should give osimertinib, but in debate he wants to give chemotherapy. That's not really a very nice thing, Dr. Sahu. Now, while Dr. Sahu was celebrating Valentine's Day with his combination partner, I was actually reading February 14th, the ESMO latest guidelines, and again they said only this much, only osimertinib should actually be given. There were 31 voters. 30 people said, yes, you should. Only 1% abstained, and I'm sure that was Dr. Sahu who convened. What about the real life study? This is what the real life study, which shows there are 2 studies which again show 20.5 months of survival over there. So let's go back to our clinic. You have a patient which comes to Dr. Sahu, who says, okay, the patient comes to him and says, I know you have stage 4, but the good news, it is EGFR mutant. Patient says, doctor, I'm so lucky to have you as my doctor. Doctor, give me the best treatment. I don't want to suffer. Oh, Dr. Sahu says, I will give you treatment of combination of TKI and chemotherapy. Patient says, chemotherapy? Doctor, but I have got a lot of your videos over there which says, you talk about personalized therapy. Is there any other option available? Dr. Sahu says, yeah, but the patient says, is the combination therapy that you're proposing less toxic? Sahu says, no. Patient says, is it associated with better survival numerically? Sahu says, no. Patient says, I hope I'll be able to tolerate it well. Sahu says, no. Patient will ask, I'm sure it's got a much better CNS penetrability. Sahu says, well, not exactly. So then they say, okay, fine, let me take this initially. Maybe I'll be able to take osimertinib later. Sahu says, not sure of that also. The patient says, then finally, Dr. Saab, is there any other way out of any way out of this? Sahu says, okay, fine, just let's not discuss anything more about it. Also, again, take a hypothetical scenario. If you have 100 EGFR mutant patients, 20 will have brain mets at presentation, osimertinib better. 15 will have poor PS, osimertinib better. 30% will never get osimertinib in the second line. Osimertinib again is better than this. 20% will be elderly. Osimertinib will be better. So what exactly do you want to give chemotherapy plus TKIs into? So this is what osimertinib is non-small cell lung cancer is. Whether you look at ADAURA, whether you look at FLORA, the results are great. If chemotherapy plus TKI was so good, then why not try it in first stage 1, 2, and 3? So this is what the perception on reality of TKI based combination. This is what Dr. Sahu actually wants to show EGFR TKI combination. But actually, when you come to clinic, this is how they fall on their straight on their face. This is what Dr. Sahu exactly showed you on the left about the GERD and the combo therapy. The actuality of this is actually this. So with this, I rest my argument that maybe single agent combination therapy is the way to go. If you want to try with combination, this is the only combination that works. And that's it. And now looking to learn from Dr. Sahu. Thank you. Get back to you. Thank you.
Thank you very much, Dr. Ullas, for that good breakup and a nice humorous presentation. Just remind me never to debate with you ever again. But over to you, Dr. Sahu, for your bit of the role of first generation TKI combo, because I am sure there is good data that you would present to convince both Ullas and the
Vijay?
audience.
Yeah, Dr. Vijay, can I just say the point, please, before Sahu starts?
Yes, please.
Sahu, just remember I'm a junior. Thank you.
I think that what I learned best about this debate is because Delhi doesn't have a CM phase now, he would be a good candidate for a BJP CM phase. And that's the take-home message, You have a selective amnesia when you come to debates. When you need the OS from some trial, you pick it up. When you need the PFS, some trial, you pick it up. But the combo never works. And that's the beauty of the Ullas debate. So now, I agree that Ullas treats and stays in a 5-star hospital. So he doesn't know the reality of India, actually. So let me just put into, I saw that chart which you showed, Ullas. But fact is, when you talk to the patient, they ask you, Doc Saab, kitna kharch hoga? And that is a part of the science. That's why you have a term, Ullas, called pharmacoeconomics. And that is how it is done, because nothing comes for free. So now, is osimertinib the best option for first-line treatment in EGFR mutation advanced lung cancer in 2022? Before I start, Ullas has eaten 20 minutes of the debate time, Vijay, and that is what it is. Because he had to speak so much to convince everyone, because there was nothing to, because people were not convinced. So what he did was, he spun a fairy tale about the drug called osimertinib. And that is something that Ullas needs to remember. These have been only fairy tales which you spoke about. So now, let's come to combination. Is there a rationale? Is there evidence and its level of evidence? Is it applicable to all? Toxicity which he spoke about, I'll speak about the toxicity which Ullas did not mention about. He spoke about neutropenia as he has never seen a neutropenia. He did not speak about febrile neutropenia. And that's what all of us are concerned about. I am not bothered about a 2000 TLC which comes to my OPD on day 8, because all these trials have this documented weekly CBCs to be done, but they don't have fever. Do you admit them, Ullas? No. Do you give them anything? Max, you tell them go home, or some of our oncologists who give them a GCSF. That's also without evidence. The cost benefit analysis is something which Ullas, I will show you, and probably that will open up your eyes to the world, and that's how it should be. So is there a rationale first? If you look at it, that is a definite rationale for combining chemotherapy to the TKIs. And it has shown that they have a synergistic effect. And that has been well proven in the preclinical studies. So first, is there a rationale for combining? Yes, there is a rationale for combining. So let's look at the NEGH 009. I knew that the update thing was there. I should not have told you in the morning, and then you would not have put this up. So I did not, but yes, if you look at it, this is the data which has shown the maximum survival of around 51 months. It's not 53, now it's 51 months. And that is something that we need to remember. That landmark, I didn't hear you, Ullas, you never spoke about the FLORA OS. Ullas, it is 37, 38. Ullas, kitna tha ye? FLORA ka OS? Ullas, you are muted?
You want me to say that?
Yeah, please. OS in FLORA was how much?
38.
Ah, great. So now we record
comparison, Dr. Sahu.
So now Ullas, mute yourself. Okay.
Dr. Ullas, let's how continue, please. You'll get your
Yeah.
rebuttal.
So now, this is what it is about the TMH. I'm speaking just to the OS. He spoke about the toxicity. He spoke about Tata Memorial, which many people did not tolerate the 4 doses of chemotherapy. That's because Dr. Ullas, they were brave enough to take a real life scenario of 20% who was PS2. And that's something, the reality of the life. And if you look at it, the presence of brain metastasis were around 20%, which accounts to the radiotherapy usage which you spoke. And all of us know that symptomatic brain mets, you would go for a radiotherapy, and definitely in a government hospital, and in the Indian scenario, WBRT is the way to go ahead. So that probably answers the part of which you told about. But in spite of having a 20% patients who were PS2 and 20% who had a brain metastasis, still they could achieve their PFS and OS data. And mind you, the hazards, I'm not looking at absolute values here. The hazards for the TMS data was around 0.5. And that's what I want to remember, that there's a 50% benefit of giving a combination versus a gefitinib. And I will show you the hazards of our favorite trial called Flora. And if you look at the Chinese, this was again the design, and look at the hazards again sitting on the 0.56. What I see in the whole thing is, I'm looking at a drug combo which is consistently across trials showing you a definite hazards of around 0.5, 0.6. And that is what it is, that multiple trials have shown you one simple thing: you have a 40 to 50% benefit of a combination versus the single agent TKI, which, mind you, Flora did not show. It was a peer for 20% benefit. That's 0.8 hazards. And look at the Flora and look at the analysis. And this is what I was speaking about. It is 0.799. That's the OS. And mind you, the hazards of OS compared to the hazards which I showed you. And do not forget the initial hazards which was shown for OS in Flora, the interim analysis was 0.6. This has actually fallen. 2 more patients on this side, Ullas, the CI would have just crossed the line of 1. And if you look at the confidence interval, it is 0.641 to 0.997. Just missed it. I don't know whether they took out 2 patients to even fulfill these hazards. That's something which I am not have evidence, so I cannot accuse them of that. You showed this lovely PFS data. All of us agree. Look at the PFS across the combination. It is really the same. Yes, I will speak of subset analysis, because my patient is one of the patient in that subset. My patient is either having that L858R mutation, or is a Asian, or has the PS2, or has a brain mets, like you told in leptomeningeal. You look at a particular drug. So subset analysis is the essence of how you want to treat. So look at the subset analysis for OS, Ullas. You showed us all those lovely forest plot. This is Ullas of Flora trial. Is anything even not touching the line of the one line? No, it is all across. You don't have anything that is falling into the left side of osimertinib. What were we showing for that hazards or forest plot, Ullas? This is the Flora's forest plot, which is showing that nothing actually is better. And if you look at the Del 858R, and this was actually sitting on the 1. And look at females. You spoke about it. See this female thing. It's again crossing the 1. So what you're speaking of OS also is applicable for the Flora. But look at the same OS thing for the TMS data. Everything is nicely sitting on the left side, which is favoring the combination. And if you look across the OS for the Chinese data, again favoring only the combination arm. So what I meant to say is response rates. Let's have a look at the response rate. And these patients are basically bulky disease. My patient load are very sick. They come to us late. I would have to have lovely responses. You look the responses across, they are looking to the 75 to 80% of these data. And look at all the data which you look across the combination is sitting around 80-85%. The Flora is sitting at around 70-75. So I would look at a more effective response rate if I use as a combination, which probably we have seen across these subsets. Now we are talking of immunotherapy and chemotherapy combinations. Also, the CNS agreed. This is a giveaway that the osimertinib has an advantage, but it does not mean my combination does not work with the CNS disease. And look at it. The Chinese have shown that. The TMS data has shown that in CNS metastasis, the combination of gefitinib and the chemotherapy does do good. And the hazards is very, very impressive. This is very important for me. People have to see this slide. If I have a treated CNS meds, already known meds, I probably have better benefit of osimertinib. But the new CNS disease means not the patients who did not have CNS at entry for a flora. I don't think there is much of a difference in the gefitinib versus the osimertinib data. The difference is mainly the patients who already had CNS disease as presentation to develop the recurrence of the CNS disease. That was something I feel the osimertinib did help. Asians, non-Asians, I have to speak of that because half the world is not sitting in the US or Europe. They are sitting in this part of the world, which is Asia. And if you look at it, it has been a dismal response. And if you look at it, the data for the flora, for the two subsets of Asia and the L858R, it's horrible. Look at the Chinese. You showed the Chinese data, but you probably, because I told you today, you did not read the whole article. You just read the headlines. And look at what I'm looking at. The OS for the Chinese, as again the hazards is around 0.8 to 0.85. And this is statistically insignificant. I concede it was not powered for that. But look at the hazards. The benefit is poorer than the OS benefit what you see in the whole population. And look, this is the Chinese flora. This is the Chinese flora Ullas. And look at the EGFR mutation. Again, the same thing comes around even on the PFS, that it is not a very active drug on L858R. And the OS is again the same. It is just a dismal drug. And you spoke about how many in the TMS data got osimertinib. I want to tell, in the trial, in like Flora, where had the drug, they had the opportunity to give everyone osimertinib. Only 30% of the patient post gefitinib failure receive osimertinib. And mind this, take this into context with the OS has a confidence interval which I showed. If 60% of this patient, 60% of this patient who were eligible for osimertinib would have got osimertinib on progression for gefitinib, I'm pretty sure your OS would have been sitting under stark, the hazards would have been 1.2 in favor of the gefitinib followed by osimertinib. So this is the reality. When you want to skew a trial, do not provide osimertinib post progression. You just give half the patients osimertinib when the flora or sponsors could have given it to all the patients. So this is something very important. Why not first line? You told of the rare mutations. Tata had the rare mutations. Even I have a better drug called than osimertinib, afatinib. I would probably give that. I would probably have a real life data of the geotag trial. Although with all the criticism, it has shown a benefit of OS which we have not seen in the real life scenario. 45 months to 50 months. And this is something which is very, very important. And now I have 2-3 more slides. Look at the, if I rank it as per the OS data. If I go for it, the way the OS data has come, the 52 months is the NEJ009 for Japan. It is 52 months, so it takes the gold position for me. The second position I would give to my erlotinib and bevacizumab combination. That is it. Second, and the third will go to my TMS guys or the Chinese guys or the sequential geotag. And Ullas, with all your effort, you still miss the bronze. You will be the Milkha Singh of the Rome Olympics who just missed the bronze medal. And then come down to this one population. Ullas, we spoke about, we debated together when we had COVID. Now post-COVID, do you know this data from the Japanese relay subset? This trial shows you that when they gave a erlotinib-like thing, it was 0.1% for interstitial lung disease. And if you look at the flora subset of Japanese trial, it was 12% interstitial lung disease. Ullas, is it easy to treat interstitial lung disease? And you have 12.3% of the patients in the Japanese subset of flora who had interstitial lung disease. In Chinese trial, that even did not mention the word ILD. I would love to see that. I'm very sure the ILD in the Chinese flora also would have been the same. So are you saying that is a safe drug? Do you know what is the quality of life for ILD patients? Now coming to the reality, cost effectiveness. Even a country like US and Brazil, the cost effective studies told that in US, you need to discount the drug by 20%, not cost effective. If you come to against a study like for osimertinib cost effective for US and China, it is not cost effective. For UK, it's only cost effective for second line, not for first line. So across the world, at the cost it is given, it is not a cost effective drug. Last, some more facts. We live in a country called India, and we all love our country. It is shining, but is it really that much shining? We still are very poor in our poverty index. we still are not as good in the money in the pockets as some other countries. We are 99 out of the 180 odd countries. In the global multidimensional poverty index, we are in the last 5. So we have to take things in context. Osimertinib for me would cost me 30 lakhs 60,000. Very few of us could afford it in my country. Afatinib followed by osimertinib could be something little more costly, but my pemetrexed carboplatin gefitinib Ullas is around 2.76 lakhs, and that is also for 1 year of therapy or maybe 1.5 years of therapy. I think even the BPL, the Ayushman Bharat also agrees to that fact. That's why this is the only combination they have put it. So this gives me validation that in India, even a government program only has validated this combination. So now the choice is yours. So I end up with, is there a rational Ullas? There is a rational. Is there evidence? There is evidence. You showed only one trial. I've showed you 7 trials. What more do you want? Is it applicable to all? It is applicable to all. Across subset, across subtypes, across Asians, non-Asians, Westerners, it is there. Toxicity, there are issues with toxicity, but that was nothing that we could not handle. There were paper toxicity, and the discontinuous rate was something that I would not be very much worried about. Cost benefit, is there any other doubt? US also tells you that we need a drug 20% cheaper. What more would you say of cost benefit analysis? So last, this is how you are looking now, or even on the screen. You are not able to realize, take a screenshot, see it later, and you will always see that you have been looking like, it's easy, exactly, take a screenshot now. And this is how you're looking actually. So this is, Arey, ye kab hua yaar? Ye kab laga mere ko yaar? This is what the reaction is. So bhai log, all the listeners, jago, doctors jago. Ullas is sitting in a 5-star hospital. We are the doctors treating the general population, treating the poor. And if I can do it at 10% of the cost which Ullas is spending, I feel we are doing a better job, Ullas. And I do not have to recommend something that makes my patient BPL the next year and makes him eligible for the Ayushman Bharat next year, although he was eligible with the car this year. So with that, I stop here. And thank you, Ullas. It was always lovely debating against you.
Thank you, Dr. Sahu. Thank you very much for that excellent talk on TKI combo. I think both of you have brought this out very nicely and very clearly in terms of the nuances of how to look at data in a much more finer detail. In a sense of time, we are not going to take on any.
Vijay, give him half a minute. Yeah, wo roega. You have to give him a minute.
Okay, Dr. Ullas, one statement from you and then one statement from Dr. Sahu.
No, I will not do anything. Let him take my time.
Sahu, just one statement. If osimertinib is 10,000 rupees, what will you do?
Dekho. Now he has come to reality.
Now tell me.
And if it is 10,000 rupees,
provide osimertinib for you for 10,000 rupees. What will you do?
If it is, cost is a part of it.
Please.
If it is 8 to 10,000 rupees outside a debate, I will give it to anyone who does not have a L858. That's the population. I'll be still very skeptical. Otherwise, I'll give it to all. That's for sure.
Dr. Sahu, you told me I'm the BJP face. You are the Aam Aadmi Party face of Delhi. With that, thank you.
Okay, thank you very much. But I think I want to summarize. I think there are options for both, and I think patient identification is probably the most important in terms of whom to give what. I do feel that both TKI with chemo combo, I'm not so sure about the VEGF inhibition, but certainly chemo combo. And most importantly, we have our own TMS data. No matter how much ever we can criticize or appreciate it, they've done a fantastic job of getting the real life data out there. This is what we see in our clinic. These are the toxicities that we see, and these are the kind of patients of that relevant performance status and brain mets that we actually see in our clinic. So I think great shout out to the TMH for doing that study for our own patients. But nevertheless, I think we all agree that a significant proportion of patients end up with osimertinib purely because of a reduced toxicity profile and good phase 3 data if they can afford it. But Dr. Sahu, excellent to bring out that clearly there is going to be a significant patient population who will go on for TKI chemo combination, and we do that in our clinic on a regular basis. Now, thank you very much for both of you for that excellent debate and really livening up this evening for all of us. Thank you very much. So we'll move on to the next session, which is a Roche-sponsored session looking at what molecular testing should be done in lung cancer, because we have this regular problem in a clinic. Do we go down this EGFR, Alcross, PD-L1, and then do a reflex NGS, or do we go up for an MGS? What testing shall we do so that our patients get the maximum benefit? So for this, we have a panel discussion, which is going to be moderated by Dr. Krishna Prasad, who is a senior consultant medical oncologist from Institute of Oncology in Bangalore. And can I also invite the panelists? We have an extreme list of panelists today. Dr. Amit Rotan, head of department for medical oncologist at Manipal Hospitals, Bangalore. Dr. Vishwajit Pai, consultant medical oncologist, Bharat Hospital, Mysore. Dr. Nidhi Tandon, consultant medical oncologist, Mazumdar Shah, Narayana City, and myself will be part of the panel. So. I will get them to put you in. Just one second. I just got a call from Dr. Krishna. Organizers, he's on the delegate. Can someone put him into the panelist, please? Dr. Krishna Prasad. Organizers, Tarun. Can you move him from attendee to a panelist? Hello. Garima, Pooja. Okay, just give me 2 seconds. Can you just give me 2 seconds? I'll just try to get Krishna Prasad from attendee to the panelist list.
Yeah, I think
Hello, I just, are you there? Yes.
Yeah, I think I'm in.
Okay.
Is my slide visible?
Yes, it is. Yes.
Yeah, thanks Vijay for this opportunity, and I'm honored actually to be moderating this session with you, Amit, Nidhi, and Vishwajit. So if we quickly start, so we know that the cancer treatment options have increased in recent decades from radiotherapy, chemotherapy, and now more and more personalized treatment. You can see that with this slide from 2004, when at least 75% of our patients had unknown mutations in lung cancer, to 2017, where I think roughly around 15% of them have unknown mutations. So growing number of these actionable mutations, pan-cancer biomarkers, and limited biopsy tissue available made us move towards a single test which is comprehensive and efficient. So the first two questions I usually have is not enough tissue and missing mutations. Let's look at this patient, a 48-year-old in 2017 diagnosed to have stage 4 lung cancer. This was the PCR test. EGFR was negative and Al-Cross was inadequate tissue. PD-L1 was 1%. So this happens frequently because, you know, if you want to do EGFR, Al-Cross, RET-MET, BRAF, KRAS, and others, the number of slides and then the amount of tissue you require is quite large. Vijay, have you faced this issue in your practice?
Sorry, I didn't get the question, Krishna.
We have this patient where EGFR was negative. ALK and ROS, there was no adequate tissue when you do it with the usual IHC method. This is because, you need so many slides to do all this. The previous way we used to do IHCs, FISH and PCR. So have you faced this issue of not enough tissue?
It's a regular issue, isn't it, Krishna? That tissue is always the issue in lung cancer. The biopsies are not easy to do. They're deep. We have risk of pneumothorax. A lot of our radiologists are concerned about taking multiple cores. I think it's a little bit better now, having spoken to our radiologists multiple times, that we need at least 5 to 7 cores. But if the biopsy is done outside, then we don't necessarily have the relevant cores. And lung biopsy is not something that the patients agree to again and again. So I completely agree that it is an issue.
Vishwajit, what about you? What test are you doing? Are you doing NGS for all, or are you still sticking to PCR in Mysore and IHCs? Are you facing this issue?
The problem with the tissues is very much a reality, sir, especially when a patient has a bronchoscopic guided biopsies. So I do face this issue on a regular basis. So many times, I tend to get biopsies, I've done it multiple times, sometimes from metastatic sites as well. So, so far, I had been doing mostly PCR based tests, but then I realized, once this NGS panel is done, it's so much easier. We are finding so many more
I think I've lost Vishwajit.
We can't hear him. Sorry.
Yeah. So I think we realized that all of us face this issue of not enough tissue for doing these tests. So if you take this patient, basically was given 4 cycles of pembrolizumab, pemetrexed, and carboplatin with no benefit. He progressed and hence was changed to docetaxel ramucirumab, developed multiple brain mets, received radiation, and then underwent a repeat biopsy. On the repeat biopsy, we found that there is a EGFR mutation. So one thing is there was not enough tissue to do some of the tests. Second thing is clearly PCR missed the EGFR. The second patient is a 56-year-old Asian female with CA lung, stage 4. With EGFR was positive by PCR, ALK was negative. NGS, hotspot NGS was done, which was EGFR negative. So now you have an EGFR positive, and the hotspot NGS did not show EGFR positivity, but showed a high TMB. So in this situation where the EGFR was positive in PCR and NGS was negative for that, Nidhi, what would your thought be? Which one would you more rely on?
Because EGFR, the clinical profile of the patient being a female, non-smoker, Asian, and also because it was not one of the rarer mutation which can be missed by PCR. I would not tend to ignore the PCR results in this case, though I otherwise usually prefer NGS.
Amit, your thoughts on this here?
Yeah, I would agree. It's very important to see the patient profile also. And I think a female, young, I would be obsessed with finding a driver mutation. And I would say if you don't find one with an NGS report saying no driver mutation, I would be suspicious. Why not? So I don't think we would ignore that other report. Normally that report would have come first for us and we would have gone by that report. So I don't think we would say that's wrong or something. You would eventually want to treat your patient assuming there's a driver and then see what happens.
I agree, Amit, totally with you. I also agree with you that 56 years old is young. As we reach that age, I think we should label them as young. So a CGH was done and CGP, and it showed EGFR mutation. So what it shows is the hotspot NGS does miss EGFR mutations. So this issue of missing mutations can happen because hotspot mutations testing is not that easy. In fact, you can see the big difference when you do a hotspot versus a comprehensive genomic profiling. Take, for example, ALK. If you use a single marker, this is how you'll pick up. If you use hotspot mutations, you will see that some of the ALK you're going to miss. And if you do a CGP, you're going to, hit many more. So a comprehensive genomic profile will pick up a lot of DNA variations, RNA variations, and also will give you signatures, which might help you to plan your treatment. Roughly around 20% is what you would miss on routine testing of EGFR, and of course for ALK and other issues also. Vijay, what is your experience been with the routine, PCR for EGFR, IHC for ALK-ROS, and also hotspot NGS?
Yeah, I mean, to be fair, I think the routine test is what we commonly do in practice. So the PCR and IHC is what we initially do, which is EGFR, ALK-ROS, and PDL1. And if they turn out to be negative, then we do start the patient on chemo plus minus immunotherapy, and then subsequently go hunting for a driver mutation, particularly if they fit the profile of younger female non-smokers and so forth. The question is which one we choose. And I think a lot of that, I mean, we would want to do a comprehensive genomic profiling for everyone if we could do, but the cost can sometimes decide whether we go for hotspot testing or whether we go for a comprehensive genomic profiling. Options are by and large given to the patients and we let them choose. But nevertheless, our recommendation has always been to go for a comprehensive genomic profiling.
So, Amit, I don't know how frequently you would face this situation, but imagine a young patient, a non-smoker, everything fits into, the EGFR or any other mutation positive disease, comes out as negative or hotspot NGS. You're treated with chemotherapy with moderate response. How tempted are you to, give a clinical trial of gefitinib, which the patient can afford, or you want to push these patients towards a CGP, which most of them will not?
So I don't think we should do that, because though we keep talking of EGFR, that's the therapy we will treat, but we have seen that, at least 10% end up with an ALK, and those definitely are going to do well with an ALK inhibitor. So it's better to try to push them to get in some form of comprehensive genomic profiling. Some things we have done a lot more nowadays is we also send off liquid biopsy. So we try to send off blood together, because that way, if we miss this, we are picking something more by that. And it surprised us that we are missing even some routine things which you miss in tissue, you can pick in blood, and vice versa. So yes, it's something that's difficult in terms of cost, no doubt about it. But I feel we should chase. I kind of agree in our setup. Really, there's nothing wrong in saying, let's do a EGFR quickly, EGFR ALK-ROS quickly, find out. But if it's negative, the whole thought is don't stop chasing. And that's what the essence is. Our population is so driver driven that we do pick up a huge number by PCR. We don't miss many. But if we don't, I think we should chase further.
Fair enough. Amit. So let's take Vijay's case. I think this is a 63-year-old lady who basically had a stage 4 non-small cell lung cancer, adenocarcinoma, and she was by PCR EGFR positive. So she was given 2 cycles of osimertinib, and she did not respond at all. Then she was given radiation, and then 5 cycles of pembrolizumab, pemetrexed, carboplatin. A CGP was done, and this is what it showed. It did not show a EGFR mutation. It did show RET fusion, PIK3 mutation, and MTAP loss, and was put on selpercatinib. So Vijay, just your experience with this, can you just share what happened to this patient actually from the beginning?
Yeah, so this was very interesting and not something that we see every day. So this patient was a bog standard lung cancer, adenocarcinoma, did the EGFR by PCR, and that came positive and was commenced on osimertinib. 2 months of osimertinib, patient was actually not getting better. And normally we do wait for 3 months, but in this situation, we thought we'll do a scan, and the scan clearly showed that disease was worsening, which is very, very surprising. I mean, but nevertheless, I think we suck it up and understand that the response rate of osimertinib is 80 to 90% and not 100%. But cost was not an issue. We started the patient on chemotherapy, and we sent for a foundation to look for other meds. other mutations. And this report came back, which was pretty surprising, that there was no EGFR mutation, but a RET fusion was seen. And so in view of this, at that point in time, we added an immunotherapy while we're waiting to see what to do with the RET. We applied for compassionate grounds for sulfacatinib, which was available at that point in time. It did take us about 3.5 months to get the drug. During that period, a patient did respond to chemotherapy, but the response was very, very short-lived. It lasted for about 2.5 months, and subsequently the patient progressed in the second imaging, which was done after 4 cycles of chemotherapy. By then, we did get sulfacatinib, which we started. A patient received sulfacatinib for 2 months. Response assessment did show a benefit. Unfortunately, patients succumbed to COVID soon after that. So that was unfortunate, but nevertheless, I think it is a beautiful example of what comprehensive genomic profiling can do. It can bring out those rare mutations which you normally not test for. And if you try hard enough, certainly for those patients who can either have access to compassionate grounds or can afford it, I think it would be the way to go. The false positive PCR for EGFR was a surprise. We have decided to let that slide and not make any changes to our protocol, just on a one-off thing. But yes, it is what it is.
Yeah, Vishwajit, your thoughts on this patient being, false positive for EGFR on PCR?
Yes, sir. Even I have come across, situations where patients have EGFR mutation, they're not responding. Now that I've seen Vijay sir's case, I think probably they had one other mutation. So that was preventing them from responding to anti-EGFR therapy. So this is an eye-opener for us to say that, a comprehensive genomic profiling is the way ahead. I think in the years to come, this is going to be it's going to replace the PCR very soon.
Fair enough. So, Nidhi, your thoughts on this false positivity on PCR? Why do you think this happens?
So, had this patient been on osimertinib for a longer time, I would have thought that he developed a TKI resistance, just like MET, he would have developed RET. But since the duration was very short, it was just 2 months, and the patient did not show any symptomatic improvement, which usually happens within 10 days to 2 weeks. Therefore, it is likely that it is false positive. False negative, I can understand, but a false positive, I really don't know the cause.
So I just came across this paper in September 2014, where they hypothesized that the panel primers promiscuously binds to nearby complementary sequences of non-targeted amplicons. So this is the reason why there is a false positive PCR sometimes. So selpercatinib, unfortunately, this patient died of other reasons, but this is supposed to be a very good drug with 64% response in a patient like how Vijay had, and the duration of response is nearly 1.5 years. So regarding this patient who also had PIK3 mutations, Amit, your thoughts on PIK3 mutations in this patient who also has other mutation, that is RET?
No, I don't think in lung we should really look at and target PIK3 mutations. PIK3 mutations are seen so commonly in so many cancers when you do NGS testing. I think it's one of the most common abnormalities you see in an NGS report, but that doesn't mean we should target it. At present, the only PIK3 I would target is breast cancer, and that also in that selected ER positive who progresses. Otherwise, I would not target this.
Fair enough, Amit. I think many times, if you actually have a PIK3 mutation, you better look for some other mutation, because generally, if you look at this, for example, only 13.5% of patients had PIK3 mutation on a standalone basis. 86.5% had some other mutation, and the commonest mutation along with PIK3 happened to be EGFR. So also there is some prognostic value. People with PIK3 mutation seem to be associated with poorer prognosis. So finally, this patient also had loss of MTAP. Any thoughts on this, Vishwajit?
Yes, loss of MTAP is supposedly, it makes the tumor and microenvironment cold. So that, decreases our response to immunotherapy. So from the articles that I've read, I think, chemotherapy is the way ahead, especially pemetrexed based therapy. So for having better response, but overall MTAP loss is not good news.
Yeah, fair enough, Vishwajit. I think you have hit the nail on the head. MTAP loss, especially when it occurs along with the CDKN2A loss, confers poor response to immuno-oncology drugs. And it sometimes, I mean, most of the times responds reasonably well, especially if you add bevacizumab to the chemotherapy thing. So also, like how all of you have pointed out, for these rarer mutations like NTRK, you need to do a comprehensive genomic profiling. So I think with these 2-3 cases, what we have learned is, one, there can be false positive and false negative reports with PCR. You have an issue with the tissues, and also the fact that you are more likely to pick up not only a targetable mutations, but you are likely to pick up other information which will give you, an idea about the prognosis of the patients, and maybe some alternative treatment which can be applied. So finally, going into last 5 minutes about liquid biopsy. Amit, your thoughts on liquid biopsy, because you just told us that you tend to send it off upfront.
I think this is a very valuable tool in lung cancer, especially where we know we have mutations and we don't have tissue. Whatever said and done, tissue always gets exhausted in some testing or the other. Even when we do NGS, we have seen sometimes we send tissue and then the NGS report comes back, the tissue was not adequate or the quality of tissue was not good. So I feel liquid biopsy has a very important role to play. I would kind of think the future algorithm is going to be liquid first, because of you can get to the reports really fast. At least you save half the time. In 12 days, you get a report from a liquid biopsy, whereas it takes about 3 weeks for us getting an NGS from a solid tissue. So I feel that's the major advantage. And one could always have an approach saying, do a liquid first. If it is negative, then do a tissue NGS. And if it's positive, you could go by that and treat it. We know that if we pick up anything on liquid, it is definitely there. But yes, there are some things which don't get picked up in liquid easily. You sometimes, when you talk of NTRK fusions nowadays in lung, we'll be talking about 1 to 1.5% with NTRK fusions. Those you're not going to pick up in liquid biopsy easily. So there are going to be some challenges, but it is a very valuable tool.
So Amit, I gather that all of us would like to send upfront foundation medicine CDX for all our patients. At present, you would also like to do that. What is a common protocol you follow now?
So I would say we are evolving, and our own protocols, if you remember how we used to speak last year and how we used to speak 2 years ago and how we used to speak 3 years ago, has changed so dramatically. So I think all of us are evolving depending on the situation we practice in and with what we are learning with reports from our patients. I would say currently what I do, if I have a tissue and I know I have adequate tissue, I just send a quick EGFR AL cross, because I know I'll get the report in a few days, and I send the blood for a liquid also. If my liquid comes negative, so I'm not doing tissue NGS for everyone upfront because it's too time consuming. You lose a lot of time on that. But again, these are evolving algorithms, and we keep changing and learning about things better.
Very interesting, Amit. Vijay, what is your algorithm now? What do you do for all your patients?
As per standard, we do our routine EGFR cross and PDL1. We get those reports in 4 or 5 days. And if they are positive, we don't do much else. We get on with treatment. Now, if EGFR ALK and ROS are negative, then we do talk about chemo, depending upon the PDL1 status. But yes, if we do want to chase, which we do want in the vast majority of them, we tend to send for tissue biopsy. Our experience with liquid biopsy is quite less. Data is evolving, and I think, like Abid said, I think we need, as we probably send more and more patients for liquid biopsies, we will get more experience. But sending both tissue and liquid at this point in time is prohibitively expensive. Certainly, if you're doing comprehensive genomic profiling, you're looking at north of 2 lakhs for each one of them. So it does become very, very expensive. So currently, we're not doing that much liquid biopsy. But having said that, if patients progress on one line of treatment and subsequently on progression, I think liquid biopsy probably would play a larger role going further if you're looking for resistance mechanisms of targeted therapy. But upfront, I think the current experience of liquid biopsy is very, very limited. But we do tend to send for tissue biopsies for NGS if EGFR ALK and ROS are negative.
Nidhi, your thoughts? What are you doing in your practice as on today?
I am practicing more or less like Dr. Vijay said. So EGFR ALK cross by PCR or IHC first, if negative. And I do tend to get about, say, 30% of the patients who are quite poor and not affording. So in those patients, I send the NGS only if I know that they will be affording for the targeted treatment for the rarer mutations that are found. Rest liquid biopsy I'm using for T790M, and as you mentioned, the resistance mechanism, but not upfront as of now.
Vishwajit, your practice in Mysore, do you use liquid biopsy or what is usually what you use? Do you use
Liquid
hotspot
biopsy.
NGS?
Liquid biopsies are only at recurrences, sir. So I haven't used it upfront till now.
Right. So I think liquid biopsy, Amit has pointed out, it has a complementary role, and the sensitivity is around 75%, but specificity is 100%. So this is a trial called the BFAST trial, where they're trying to use a liquid biopsy and try to treat patients accordingly. So we are trying to use liquid biopsy to base our treatment, looking for actionable mutations. In the future, probably, are we going to use MRD and then decide on the treatment? Amit, your thoughts on using this for MRD?
I think that's going to be a very, it's a very novel and futuristic approach, no doubt about it. We have seen data from, like what you're showing here, there was this stage 3 data in Pacific, which showed that patients who were MRD negative post CTRT actually may not have required durvalumab for a year. They do so well. But the number is so small, so I don't think we can say that. But there are a lot of adjuvant trials which are now looking at it. I know there's a durvalumab trial also in the adjuvant setting, which is actually looking at ctDNA and then stratifying them to say that should we give them adjuvant treatment or no adjuvant treatment. But I don't think we are there yet. This is a very interesting field which is going to open up in future, and I'm sure it will open up. I think whatever we say, whatever we think, no, this is not useful as of now, but the way the field is changing, I think very rapidly we'll be seeing all these data sets.
Fair enough. Vijay, what is your thought, about using it for immunotherapy, for example? We use liquid biopsy, look for tumor mutational burden, and based on that, use immunotherapy. What is your thought?
I think, again, it's a good concept stage. I think we need more and more data. There is some data coming out. The tumor mutational burden on its own is quite controversial to begin with. There is some data on first-line therapy, but the TMB is itself not standardized. Different labs have different cutoffs. Access to it is difficult. Quality control is not standardized. So I think we've got a long way to go before we start using TNB in our clinical practice. But yes, I think the future is there. It will be exciting to see how liquid biopsies TMB influence our decision making. We're not there yet, but I think the future we probably would be. Krishna, we need to finish.
Yeah, that's why I will put this last slide to say that comprehensive genomic profiling is probably the way forward. It to a large extent solves the issue with the tissue. It is quite very sensitive, very specific. You're going to pick up rarer mutations and more information which can impact your clinical decision making. Liquid biopsy is the way to go forward, probably. With that, Vijay, I thank you for this opportunity, and I'm honored to moderate all of you. Thank you.
Thank you, Dr. Krishna Prasad, for that excellent session. And thank you to all the panelists, Dr. Ahmed, Dr. Vishwajit, and Dr. Nidhi for making this session very, very interesting and exciting. I think we've got a lot of take-home points when we go back to clinic and obviously consolidate and learn from each other's practice.
Thank you, sir.
But we agree that molecular testing is the way to go, and we should probably hunt for mutations even if we don't find any in initial testing. And I think that's the key message, is whether we use a tissue biopsy or liquid biopsy, but NGS is probably the way to go. Thank you all very much. Thank you. So we'll move on to our next session, which is AstraZeneca session. We have two excellent talks before we close for the evening. The first talk is by Dr. Sai Vivek, who's a medical oncologist from Bangalore Shankara Hospital, and he's going to talk about newer paradigms in resected EGFR mutated early lung cancer. So Dr. Sai Vivek, are you there? I can't see Sai Vivek on the list. Dr. Sai Vivek? Okay. So whilst we are trying to connect with Dr. Sai, can we move on to Dr. Aditya Murali's session on the optimal management of EGFR mutated non-small cell lung cancer patients? So Dr. Aditya is a senior consultant medical oncologist and hemat-oncologist at Aster CMI Hospital, Bangalore. Dr. Aditya, are you there? Aditya? Can I ask the organizers to get in touch with Dr. Sai Vivek or Dr. Aditya, please? Give me a minute, I will come back to you. I think we've got Sai Vivek here now. Yeah, hi, Dr. Sai, welcome. Are you on?
Hi, sir, good evening.
Hello, hi. Sorry, I think your bandwidth is a little slow. I can't see you properly.
Hello.
Hello, hi, Dr. Sai. Are you there? It might be easier if you switched off your video and just concentrate on audio.
So am I audible? I think I'm having a network lag.
Yeah, I mean, if you just switch off your video, you would have the bandwidth that you need. Yep.
Now, sir?
Yeah, better. So we have Dr. Sai, who's going to talk to us about newer paradigms in resected EGFR mutated early lung cancer. Over to you, Dr. Sai Vivek.
Yes, sir.
Do you have your slides?
Yeah, I'm just sharing my screen, sir.
Okay.
Yeah, good evening, everyone. I would first like to thank the organizers for this opportunity, and I hope my slides are visible and I'm clearly audible.
You're audible, Dr. Sai, but we can't see your slides.
What about now, sir? I'm sharing them. Can
you put them on full screen?
Yeah, it is on full screen, and it says that I am screen sharing at the moment. And this is in the PowerPoint full screen view. What about now, sir?
I can't see. Anyone else? Can they please chip in to let me know if you can see the slides?
So close all the other windows and again stop sharing and start again. Close all the other
I'll
windows.
do that.
Yeah.
Yeah, now it says participants can see your screen somehow. What about now?
No, Dr. Sai, we can't see your screen. Dr. Sai, can I ask the IT people to connect with you to sort this out while we do the next talk?
No
In
problem,
next
sir. Done,
time.
done.
Okay, so I think we'll move on to the
Done.
next session with by Dr. Aditya Murali, who's going to talk to us about optimal management of EGFR mutated non-small cell lung cancer. And in the meantime, I'll get the IT support to talk to Dr. Sai Vivek to sort his presentation. Thank you. Over to you, Dr. Aditya.
Thank you I would definitely like to thank Dr. Ullas Batra and Dr. TP Sahu for a very, very engaging debate. And that has made my job a lot more easy than what I expected to. And with due respect to Dr. TP Sahu and all the relevant points that he made over the next 15 to 20 odd minutes, I would like to try and reinforce what Dr. Ullas Batra, the point that Dr. Ullas Batra tried to make, which was how do we manage our patients with EGFR mutation in advanced non-small cell lung cancers, and what is the best way of getting them the best possible outcomes. So I hope my slides are visible and I'm audible.
Yes, Aditya.
Yeah, okay, great. So I will skip through most of the data initial slides which I have. We all know lung cancer is a huge problem. It's the same all across the world as it is in India. In India, this is the most commonly diagnosed cancer. And unfortunately, this is the leading cause of cancer deaths, which accounts for nearly 18% of all cancer deaths. Globocon 2020 data came out a couple of years back, and this did highlight a lot of things which we thought weren't happening in India. People always thought that oral cancer was the biggest burden amongst Indians, but it does turn out that lung cancer is also equally big. 8% of all new cancers diagnosed in 2020 were lung cancers. That translated into an absolute number of about 50,000. We do know that this is the tip of the iceberg, and most likely the numbers are going to be far more than what we have right now, or what the data does say over here. Quite unfortunately, 66,000 deaths happened due to lung cancer in the year 2020. So what do we need to do to change these statistics? How can we make our patients do better? Using the best drug first will maximize the benefit to all EGFR mutant patients of us. And this is the change in the treatment paradigm, or rather the change in the philosophy which oncology has undergone in the past decade or so. What are the first line options that we have? Just like we have a 2G, 3G, 4G, and now a 5G, we have first gen, second gen, and third gen with varying pros and cons of use in the first and second line. So let me start by talking about how important it is to have a third generation inhibitor like osimertinib in the first line. Let me just start this point by saying that osimertinib has been given a preferred or a category 1 recommendation by NCCN for patients who have a EGFR mutation in advanced non-small cell lung cancers. How is this different from the second and the first generation drugs? What I want us to pay attention on is that osimertinib is a third generation inhibitor, and it has a irreversible binding to the EGFR receptor, whereas the first generation binding is basically reversible. So that is the first big difference. The second big difference is that EGFR has a significant ability to cross the blood-brain barrier, and that does make a lot of difference. And all of this is purely because the targeting is actually the covalent modification of the ATP binding site, which is cis 797. However, when we look at the first generation inhibitor, the actual site of binding is a reversible binding to the EGFR ATP binding site. A little bit about what second generation TKIs do. Afatinib is our second generation TKI, and apart from binding at the cis 773 binding site, it also does bind at the HER2 or the cis 805 site. So osimertinib is an irreversible CNS active EGFR TKI, which has been developed to selectively target both EGFR sensitizing and the EGFR T790M resistant mutations. And as you can see from the animation here, the drug not just binds to the commoner exon 19 and the L858R deletion, it also does bind to the T790M mutation site as well. This leads to inhibition of the T790M mutation. However, osimertinib does not have any activity in the wild type EGFR, and this does cross the intact blood-brain barrier, and this has been seen in human and preclinical models. And the translation of this benchside science was demonstrated in the path-breaking FLORA trial. This was a phase 3 study to assess the safety and efficacy of osimertinib versus standard of care EGFR TKI as the first line treatment in patients with locally advanced or metastatic non-small cell lung cancer. So interestingly, FLORA chose a primary endpoint of PFS and a secondary endpoint of overall survival. So FLORA was a straightforward shootout between osimertinib, which is the third generation TKI, versus geftinib or erlotinib as the standard of care treatment arm. Patients included all treatment naive patients, and significantly we have to note that stable CNS metastasis was also allowed. Patients with exon 19 deletion 7 deletion 19 and L858R were the other inclusion criteria. So patients were stratified based upon the site of mutation and the actual race. This study also allowed for crossover, and I'll talk about the significance of this a little later. So as far as the curves go over here, the KM curves show such a early separation. The separation was as early as 6 weeks. The median PFS was nearly 19 months with osimertinib versus about 10 months with first generation TKIs, and PFS is a direct measure of the drug benefit. FLORA was powered to determine whether PFS benefit was a significant benefit or not, and it had an astounding hazard ratio of 0.46, which was statistically significant. These forest plots we almost never see coming from our own era, wherein we looked at chemotherapy trials in a metastatic setting. We would never see a forest plot wherein every single subgroup significantly favored the experimental arm over the comparator arm, be it somebody with a smoking history, be it somebody with a CNS metastasis, be it somebody at any EGFR mutation site. And interestingly, EGFR mutation, even if it was confirmed by a liquid biopsy or circulating tumor DNA, even across all of these subsets, osimertinib definitely did better than the first generation TKIs of geftinib or erlotinib. Overall survival, and this was presented in 2019 ESMO, and I was a part of this path-breaking talk which was given in 2019. The hall was full and everybody was waiting with bated breaths, and all of them did get their more than their money's worth. This was the first time that in advanced non-small cell lung cancer, a median overall survival of more than 3 years, that is 38.6 months, was demonstrated in a trial which was actually powered to look at overall survival. Osimertinib patients were more likely to be alive both at the 2 and the 3 year landmark, and this was the first time an EGFR TKI has translated a PFS to a significant overall survival benefit. Nearly 30% of the patients were still receiving osimertinib at the 3 year mark. Very importantly, what was the time to first subsequent treatment? And more often than not, the first subsequent treatment was going to be chemotherapy. And we all know that when we talk to patients about chemotherapy, that definitely does translate into a worsened quality of life. So if we could improve the quality of life and keep it such that for a prolonged period of time, that also does make a lot of difference during the treatment lifetime of our patients. So in osimertinib, the median time to first subsequent treatment was more than 2 years. When somebody went on the first generation TKI, it was just about half of that at about 13.7 months. Again, hazards were very significant, was 0.47. So osimertinib provided unprecedented improvement in the FLORA trial. And when we look at various subgroups, be it on the PFS or in the OS, most of the places the PFS subgroups did show a significant benefit in the forest plots. When we looked at overall survival across most subgroups, although in some of them it was not very significant, across most subgroups the overall survival was also significant. So osimertinib's PFS benefit was clearly maintained consistently across all subgroups. demonstrating its superior benefit across all population, including by race and across the different mutation types. All OS subgroups showed a positive benefit in favor of osimertinib, although the magnitude of benefit actually varied, and this is consistent with the PFS data of other subgroups. Now, let me jog back to how the first generation TKIs fared, and this slide is one single snapshot of how gefitinib or erlotinib did, and this is real world data collected from Indian patients. So we know that studies done in Tata, the study 1 and study 2, they did show the overall survival of about 6 months to 18 months. Robert Lewis did a study of which I was also a very small part at ADR, and then in a very small subset of about 48 patients, the overall survival shown here was 10 months. Dr. Vanita Naronia, again the path-breaking author of the PEM-carbogefitinib trial, her team did show an overall survival of about 21 months, but this was the maximum overall survival shown for any Indian study with first generation TKI. And when we compare this with the overall survival of 38 months with osimertinib, there is basically no comparison at all. So how about sequencing? What if we try and put a second generation TKI and then do osimertinib? So this slide talks about a straight shot comparison of what the Archer showed and what Flora did. Archer was a straightforward combination, straightforward study which compared dacometinib as the experimental arm versus gefitinib as the comparator arm. We need to note that erlotinib was not one of the comparator arms. However, Flora included both gefitinib and erlotinib in their comparator arms. When we look at the inclusion-exclusion criteria of Archer, did exclude patients who had any CNS metastasis, be it stable or unstable. They excluded all of them straight away. Again, if anybody had a history of suspected or diffuse non-infectious pneumonitis, they were straightforward excluded in the Archer trial. Flora included patients who had a stable CNS metastasis. So we can see that, by these curves, although there was a PFS benefit in the dacometinib study, we know that the actual benefit was seen only by about 6 months after being on the study drug. So the separation of curves happened at around about 6 months period. We do not, and if we have to counsel our patient in the OPD tomorrow and say that you need to wait for 6 months before we see a difference, although you pay more for this drug rather than the other drug, patients will end up questioning us. However, when we talk about osimertinib, the separation was almost immediate. The separation was as close as 6 months, as close at the 6-week mark only. We knew that it did far better than the first generation TKIs. So overall survival was not statistically significant because the way this trial was set up was that it was a sequential analysis of all the survival data. The minute the overall response rates did not become significant in Archer, overall survival could not be statistically computed over here. However, in Flora, for the first time, an EGFR TKI has translated PFS to a significant overall survival benefit. This is some real world data which was published in 2020. This looked at the Canadian consensus study, and then this trial showed that because the Archer trial had a hierarchical stratified statistical design and there was no significance in the overall response rate, a p-value actually could not be given to overall survival. So just to completely compile what I discussed in the last 3-4 slides, the dacometinib landmark trial had a KM curve which separated at 6 months, whereas Flora had a KM curve which separated at 6 weeks. The overall survival, the overall response rates was not significant in the dacometinib study, and overall response rates in osimertinib were very significant. Dacometinib was an open label study, however Flora was a straightforward double-blinded study. Significantly, no CNS or leptomeningeal mets were included in the dacometinib study, and Flora did include all patients with stable CNS metastasis. The final word about any study drug is how tolerable it is for our patient. Nearly 2/3 of the patient who went on the Archer study needed some kind of a dose reduction. However, when we talk about osimertinib, only 3% of the patients needed some kind of a dose reduction. When we talk about the other second generation TKI, which is afatinib, afatinib failed to improve overall survival versus gestotinib in the LUX-Lung-7 trial. So and that is no longer even a standard of care in first line when we talk to our patients. So this is basically a cross trial comparison, which we generally should not be doing. But when we try and compare LUX-Lung-7, Archer, and Flora trial, the most important thing is, how soon am I going to get better, doctor? That's what our patients ask. And to answer that question, if my patient is given afatinib, they will get better at about 12 months. If they are giving dacometinib, they will get better at about 6 months as compared to geftinib. However, if they are giving osimertinib, they'll get better within 6 weeks as compared to geftinib or erlotinib. The final part of my talk is about brain metastasis. I will not spend too much time on this, primarily because Dr. Ullas has gone through all of this. Very importantly, osimertinib has demonstrated high brain penetration. In Flora, both systemic and intracranial efficacy were analyzed. Osimertinib showed superior efficacy. Osimertinib is the only EGFR TKI to report intracranial efficacy till date. This slide looks at the KN curves and CNS progression events in patients who had known or treated CNS metastasis. Across both these subsets, the hazard ratios were quite significant at about 0.47 and 0.46. When we looked at the intracranial PFS and the full CNS analysis subset, the intracranial PFS for patients who went on osimertinib was not even reached, as compared to 13.9 months when somebody took the first generation EGFR TKI. So we know that, if somebody has been newly diagnosed with brain metastasis, and even Dr. Sahu had to concede to this, patients with EGFR mutation who had brain metastasis upfront and who had NSCLC as a primary tumor, osimertinib does automatically become the first line treatment choice. We know that as far as tolerability goes, osimertinib had a fantastic safety profile. Only 3% of the patients on the landmark trial had to undergo some sort of a dose reduction. So all of this talk about the same as compared to the LUX-Lung-7, wherein about 42% of the patients who went on afatinib had some dose reduction needed, and about 2/3 of the patients on the dacometinib trial, which is the Archer trial, who needed some sort of a dose reduction. When we talk about patients in the geriatric age group, and in India, many patients, unfortunately, with non-small cell lung cancer do qualify under this. There was a higher incidence of grade 3 and grade 4 adverse events, with a more frequent discontinuation rate with dacometinib. So essentially, what is the synopsis of why we think it is important that patient receive osimertinib in the first line? And this slide has been discussed and dissected fairly frequently in the last couple of years. Just to reinforce one single point, 1/3 of the patients already have T790M at first progression, so they straight away do not they straight away end up benefiting with osimertinib in the second line. But what about the other 2/3 of the patients? 1/3 of the patients who receive first generation TKI in the first line do not end up getting any second line therapy. So that is straight away 1/3 of the patients who do not get a benefit of the better drug. There will be 1/3 of our patients in whom we will not know whether the patient has T790M or not, and unfortunately they too might not end up getting osimertinib. So it is very important that if we have a drug which we know is better than what we are using currently, we need to offer it to all of our patients and not risk even 1% of them not having a shot at getting a better drug, let alone 30% of them. So geotag is the final bit of my talk. Geotag is something that even Dr. Sahu and Dr. Batra discussed quite a bit about. I will finish very quickly. Sequencing of, when we talk about EGFR, sequencing of EGFR TKIs, starting with prior generation EGFR TKIs and then treating those that develop EGFR TKIs with osimertinib is not optimal clinical care, purely because we are not smart enough to figure out who will get the EGFR T790M mutation, number one. Number two, not everyone will be well enough to receive additional treatment, and 30% of patients in both arms received no subsequent therapy. Tissue or liquid biopsies are not always successful, and above all, we need to give overall survival has to be the main aim for any patient with any cancer for a medical oncologist. And all of this data confirm that osimertinib is the first line standard of care in patients with metastatic EGFR mutant non-small cell lung cancer. I like to thank AstraZeneca for generously agreeing to sponsor a part of this lung cancer event. I like to stop my talk over here and happy to take any questions.
Thank you very much, Dr. Aditya, for that excellent talk on the management of EGFR mutated non-small cell lung cancer. And I think for the benefit of time, we'll just move to the next talk by Sai Vivek to look at the same thing in an early lung cancer rather than the metastatic setting. I think because there's some exciting data that has come out recently looking at EGFR mutation in early lung cancer. So over to you, Dr. Sai Vivek. And thank you very much, Dr. Aditya, for that excellent talk.
Yeah, good evening, sir. And I'll start off immediately for the want of time. And I'll just try once to share my screen. If not, the organizers will be sharing it for me. And can everybody see my screen now?
We can see, but it is all black, so it's not visible. Anything is not visible.
What about now? No?
No, sir.
I think you can start sharing it.
Okay. So
I'm stopping the share. Yeah, I stopped the share. Can you please share it for me? We can start away immediately.
yeah. Can you see this, sir? No? You can proceed.
Yeah, I can see now. So good evening, all. I would firstly like to thank the organizers for this opportunity. And after that exciting talk by Dr. Aditya, now, as with any drug, we are going to start looking at osimertinib in the adjuvant setting. We know that 1 in 3 patients with NSCLC present with resectable disease, but in our country, that's even lesser. And lung cancer, as we know, is the leading cause of cancer death. It accounts for more than 1.7 million deaths annually, and as many deaths as breast, prostate, and colorectal cancers combined. Now, that's quite a lot. And NSCLC represents 85% of all lung cancer cases, with an estimated 30% of patients presented with resectable disease at diagnosis, and which is much, much lesser in our country. And can you go to the next slide, please? Yeah, and we know the outcomes after surgical resection and adjuvant chemotherapy vary quite a bit from stage 1B to stage 3. With stage 1, a 5-year recurrence rate of 45% is seen. So even a stage 1 a patient who has undergone complete resection followed by adjuvant chemotherapy, which is the standard of care, 1 in 2 patients do have a recurrence. When we go to stage 3, it becomes almost 75% of the patients do have a recurrence. Next slide, please. Yeah. So based on a limited number of studies, we know that the EGFR mutations differ between Caucasians and Asians. In Asian population, so from stage 1 to stage 4, the prevalence of EGFR varies from 34% to 54% in stage 1, to 24 to 47 in stage 2, 27 to 47 in stage 3, and 33 to 48% in stage 4. This is in the Asian population. And if EGFR TKIs were available in the resectable setting, a similar proportion of patients may be able to benefit compared to the advanced setting, as we have seen just now, that it is without doubt one of the drugs to watch out for. So osimertinib as adjuvant therapy in patients with stage 1B and 3A EGFR mutation positive NSCLC after complete tumor resection was evaluated by the ADAURA trial. So it was a double-blinded phase 3 international randomized control study where both Asians and Caucasians were included. And the inclusion criteria consisted of patients above 18 years for the Caucasian, and for Japanese and Taiwanese, it was more than 20, PS of 0 to 1, and confirmed primary non-squamous NSCLC with an exon 19 deletion or L85R, brain imaging if not completed preoperatively, and they had to undergo a complete resection with negative margins. And the maximum interval between surgery and randomization was 10 weeks without adjuvant chemotherapy and 26 weeks with adjuvant chemotherapy. And they were stratified as per age, EGFR mutation status, and race. They received osimertinib 80 mg once daily or a placebo once daily. And the treatment was for 3 years. The primary endpoint was DFS by investigator assessment in stage 2 to 3A. designed for superiority under the assumed DFS hazard ratio of 0.7. So it was, they were looking to find out the superiority. And secondary was DFS in the overall population, that is including stage 1B. So, and DFS at 2, 3, 4, and 5 years, and overall survival, safety, health related, and quality of life parameters. But what has happened is, following International Drug Monitoring Committee's recommendation, the study was unblinded early due to an unprecedented discovery of efficacy. And here they have reported an unplanned interim analysis. So at the time of unblinding, the study had completed enrollment of all patients, and most of the patients were followed up to a duration of 1 year. So this was an unplanned interim analysis. So as we have just gone through the inclusion criteria, I'm just going to quickly go, skip through this. And one thing that we need to notice here is, for patients who have had only segmentectomies or wedge resections, they were excluded. Next slide, please. So as we can see, between the experimental and the control arm, both the groups are very well matched, including the stage at diagnosis. There were 32, 34, and 35% of them were in stage 1B, 2, and 3, like in the placebo group. And even the exon 19 deletion or the L85R were well balanced among both the groups. And even the people who received adjuvant chemotherapy, yes or no, were well balanced. One thing to know that 25 to 30% of the patients in stage 1B had received adjuvant chemotherapy, but almost 75% of the people in stage 3 here had received adjuvant chemotherapy. And these Kaplan-Meier curves are something which are a wonder for all of us to see. There's very early separation of curves. And what they found was, in the probability of disease-free survival after a follow-up of almost close to a year, osimertinib definitely decreased the disease recurrence with a hazard ratio of 0.17. That translates to an 83% decrease in recurrence in the study primary population and in the overall population. The primary population, as we know, was 1, 2, and 3A. That was the primary objective. In the overall population, it decreased the risk of recurrence by almost 80%. So this is something which is much better than what we just saw in the metastatic setting. Next slide, please. So as I just said, yeah. So the DFS, 2-year DFS was consistent with the osimertinib across all disease stages. So stage 1B had obviously the lesser hazard ratio for at 0.39. Stage 2, the hazard ratio was 0.17, and 3A, it was 0.12. So in stage 3, a person had an 88% decrease in recurrence. Next slide, please. So here again, if you see the forest plot here, almost all the subgroups benefited from adjuvant osimertinib. One thing that I would like to point out here is non-Asians and Asians. Non-Asians definitely did a little better compared to the Asians. And again, stage 1B, as we expect, definitely had a higher hazard ratio of 0.39. And whether they took adjuvant chemotherapy or not, it wasn't much different. And people who took adjuvant chemotherapy definitely did better. And people with exon 21, that is L85R, definitely did slightly worse than people with exon 19 deletion. Next slide, please. So this was an early snapshot of overall survival, which is too early. The data is not mature. The study completed enrollment in 2019, and just post 1 year, it was an unplanned interim analysis. But just going by the trends with such unprecedented DFS benefit, we can expect an overall survival benefit, but I would not comment too much on it at this moment. Next slide, please. So what about the other TKIs? Have they been evaluated in the adjuvant setting? Yes. There was the SELECT study, which evaluated adjuvant erlotinib after adjuvant chemotherapy. It did show a consistent 2-year DFS benefit. And then there was the RADIANT study, which was again with erlotinib versus placebo after adjuvant chemotherapy. It did show a meaningful DFS benefit. Even the EVEN study, again with erlotinib, did show a benefit in the DFS. But one thing to note here is, this is just telling us adjuvant EGFR inhibitors definitely have a role to play in patients with completely resected stage 1B to 3A lung cancers. And even the Jeftinib study, which was done in China, showed a definite DFS benefit, but here there was not a significant overall survival improvement. We all know that people with a driver mutation, especially EGFR, tend to do worse than people who do not have an EGFR mutation if they're not in stage 4, that is stage 1 to stage 3 I'm talking about. Next slide, please. So what about the CNS mets? ADAURA definitely shows that people with who received adjuvant osimertinib definitely had a much lower disease recurrence in the CNS. So that is, we already know osimertinib definitely has higher CNS penetration compared to the other TKIs. So the CNS is a common site of distant recurrence among patients with EGFR mutation and SCLC receiving EGFR TKIs. In the adjuvant RADIANT study, 37% of recurrences in patients with EGFR mutant NSCLC treated with erlotinib had CNS involvement. And osimertinib, as we know, has much higher significant exposure in the brain compared with other EGFR TKIs. In the advanced setting, first-line osimertinib demonstrated superior overall survival and a 52% reduction in the risk of CNS progression compared with erlotinib and geftinib. So here, what they saw in the trial was very surprising. People who were treated with adjuvant osimertinib definitely had lower recurrences, and most of the recurrences in people with adjuvant osimertinib were local recurrences and very little distant recurrences compared to placebo, where the distant recurrences were more common. So local recurrences much easier to manage. So that was one more thing that they noticed in the ADAURA study. Next slide, please. So again, as we just spoke about, the sites of recurrences in the distant recurrences subgroup, definitely the number of CNS recurrences were much lesser when adjuvant osimertinib was used. Next slide, please. And the CNS DFS, so overall 45 patients had CNS DFS events in the ADAURA study, and the CNS recurrence rate was 1% compared to 10% in the placebo group. And here we can see that the risk of CNS progression was reduced by around 82%. So adjuvant osimertinib decreased the rate of CNS recurrence by 82%. Next slide, please. So the safety summary, which is again important in any trial, we can see here with osimertinib, most of us have been using it for a while now. Compared to other EGFR TKIs, osimertinib is well tolerated, with major side effects being in the skin and diarrhea. Next slide, please. Yeah. So most of the patients had diarrhea or skin issues with paronychia, dry skin, pruritus, and cough, with very little grade 3 toxicities causing treatment discontinuation. Next slide, please. One thing that they noticed was some of the patients had interstitial lung disease and some of them had QT prolongation. These two should be kept in mind while using osimertinib, especially in the adjuvant setting. Next slide, please. So people in the ADAURA study, as I had said before, almost 70% of them had received previous chemotherapy in the stage 3. So next slide, please. So the DFS in patients with and without adjuvant chemotherapy in the overall population, we can see here is with adjuvant chemotherapy, the hazard ratio was 0.16, which is very significant. And without adjuvant chemotherapy also, the hazard ratio was 0.23. So we are here talking about whether you receive chemotherapy or not in the adjuvant setting after a complete resection. Adjuvant osimertinib provides almost 80 to 83% benefit in reducing the risk of any recurrence. Again, the same forest plot here, people with and without adjuvant chemotherapy. We have established without a doubt that a clinically meaningful DFS benefit with osimertinib was observed in patients with or without adjuvant chemotherapy. Next slide, please. Yeah, especially in stage 1B, as we know, the meaningful benefit with adjuvant osimertinib was slightly less than compared to stage 2 and stage 3. So in stage 1B, the hazard ratio was okay. It wasn't available here, and with people who receive without adjuvant chemotherapy, it was 0.38. Next slide, please. Yeah. This is just a repetition of without chemotherapy, there is a clinically meaningful benefit. Next slide, please. Yeah.
So my apologies, sir, you are left with just 2 minutes to conclude your presentation.
Yeah. So coming to the most important part of any of the recent trials, that is patient-related outcomes. Next slide, please. So ADAURA, patients in ADAURA were given the SF36, SF36 had a quality of life health survey was done, which had 2 components, mainly the physical component summary and the mental component summary with 8 health domains. And we can see most of the patients, almost more than 85% of the patients, both in the osimertinib and the placebo arm, were compliant with this quality of life study. Next slide, please. And what we can see by these two graphs here is both the physical and the mental components were similar between the placebo and the control arm. Next slide, please. So just to summarize the ADAURA, adjuvant osimertinib is the first targeted agent in the global trial to show a statistically significant and clinically meaningful improvement in DFS in stage 1B to 3A. There was an 80% reduction in the risk of disease recurrence or death with osimertinib, and the DFS at 2 years was 89% versus 52% respectively. And it demonstrated a clinically meaningful improvement in CNS DFS, which is very important. And the safety profile and the quality of life issues with both the arms were very similar. Next slide, please. Yeah. So now just to summarize in one sentence, there is going to be a rampant use of adjuvant osimertinib in the near future, but we still need to wait for the overall survival data. This is an unplanned interim analysis which has shown these results. So let's keep our fingers crossed and hope for the best. Thank you.
Thank you very much, Dr. Desai, for that excellent presentation. Very well done in terms of highlighting the use of osimertinib in the adjuvant setting. I think the biggest question going forward would be, of course, the overall survival data, but more importantly, is this going to make chemotherapy redundant, and can we use it without chemotherapy, or do we still have to give chemotherapy? The benefit is seen in both, and it's going to be virtually difficult to answer this question based on this particular trial, and maybe another trial may be required, but I doubt whether it will ever be done. But nevertheless, I think we've come to the end of a very exciting evening. We've had a lot of good discussions in terms of panels, debates, and talks evaluating the role of targeted therapy in lung cancer. And I think we really look forward to tomorrow's session, where we're going to have an equally exciting day talking about immunotherapy in lung cancer. But till then, good night to everybody, and thank you very much for every one of you being here, both participants as well as the audience and the organizers. Thank you very much.
Thank you. Thank you so much, sir, for the excellent presentation and the panel discussion and the debate which happened today. And hope to meet you tomorrow, 19th, with the same enthusiasm. So everyone, good night. And we close the meeting. So can we go offline?